So good evening, everybody from OrthoTV side, and I'll hand it over to Dr. Prateek Gupta for further proceedings. Over to you, sir.
Thank you, Dr. Ashok. Good evening, friends. I welcome you all to this 17th edition of Sports Medicine and Arthroscopy workshop. Today, we will be focusing on a very small but very important part of shoulder girdle, that is the AC joint and its pathologies. This part of the shoulder seems to be a dark area where many of us do stay away or sometimes feel a dilemma about the management strategy. So hopefully we will be able to address this in this webinar, because we've got a very distinguished faculty with us here, not only from India, but from overseas also. Dr. Kapil, Dr. Pandey, Dr. Joydeep, and Dr. Anand, Arya from UK, and all our Indian faculty, Dr. Fasil, Dr. Maheshwari, Dr. Raman Khan, Dr. Ashish, Dr. Zulfi, Dr. Raju Ishwar, and Dr. Shikhar Srivastav, Dr. Raman. So we all will be discussing today and see if we can improve or take our understanding of ACJ pathology up further. Now, looking at the sports medicine arthroscopy workshop, I would just want to show you a little picture about it. So, can you see my screen there, please?
Yes, sir, visible. Just play it on the slide mode. It's visible. Yeah.
So sports medicine arthroscopy, actually we started in 2004 as a humble beginning when we all got together at Ganga to start a symposia for sports medicine. At that time, sports medicine in India was in very, very nascent stages. And most of the places where we used to go after coming from London to say that we do sports medicine, it was not well understood. But with the help of the faculty from India and abroad, and with the delegates supporting us, last 17 years, we've been able to conduct this workshop every year in first week of March, barring Holi time. And it has been successfully attended. Alternate years, we take either shoulder or knee as the main area, and we discuss this threadbare. The whole purpose of this meeting is academic, without any frill, where we try to impart knowledge and skill for upcoming budding orthopedic surgeons, residents, senior residents, and early stage orthopedic surgeons, so as to improve whatever skill and knowledge set we have. In this our endeavor, we have been supported by many of our partners, and one of them has been Smith & Nephew, who has in last 17 years constantly stood by us for giving us the logistic support to be able to conduct it year after year. And so has Sanofi in last few years joined. And I wish to thank them, and also our other co-sponsors who have helped us to do this seminar, like McLeod, Cystopic, Intas, and Pharmac. This has been a journey with all these people which has come so far. And I wish to thank all the delegates who have actually joined in today. We have got registered delegates of about 300, and others will be online on the social media. We will know the numbers after a little time. We hope that we will be able to come up with the expectation and have a scientific session where they will go better equipped after we finish this symposia. Few housekeeping rules we have already mentioned, but for those who have joined now, this meeting will have 3 parts: session 1, session 2, session 3. Session 1 will be introductory, session 2 is technique based, and session 3 is all case-based discussion. The moderator would take over and give the speakers a notice to join, and once the talk is finished, we will entertain 1 or 2 questions, 3 questions after each talk, and then at the end of the session there is a panel discussion where other questions can be taken, and further discussion can be done. For all the delegates, they can type their question in the Q&A box, and that will be picked up by the moderator and the co-moderator. Like in first session, I will be behind the scene just co-moderating, in the sense, if there's any question, then I can help Dr. Raju to place it. And then the faculty can ask question by raising their hand, and then the moderator will give them an opportunity to raise the query or answer as it would be. And as suggested earlier, we would like all of us to keep mute so that any inadvertent noise from outside will not be able to disturb the proceedings. With this, I wish to open the meeting by calling upon Dr. Raju Ishwaran to start the first session, as he is the moderator for the first introductory session. Dr. Raju Ishwaran is a senior consultant, orthopedics and sports surgeon at Max Shalimar Bagh and at Meenakshi Orthopedics and Sports Medicine Clinic. He has a long standing here in Delhi and a very well-known person. I invite Dr. Raju to start the session number 1.
Thank you so much, Dr. Prateek. A very good evening to all of you, or good morning or good afternoon, depending on which part of the world you are in. This is, in a way, the warm-up session, the introductory session. I would like to warmly welcome the co-panelists for this session. Dr. Bhasin sir, who obviously needs no introduction. He is the pillar of arthroscopic surgery in this sitting. And Dr. Prateek would also be one of the panelists for this session. Dr. Shekhar Srivastav, has he joined in, I would request him to also be the panel for this session. This session would have 3 talks. It will be led by Dr. Ashish Acharya, who would speak on the injury pattern of the AC joint and the clinical anatomy, followed by Dr. Shashank on the clinico-radiological assessment. Both these gentlemen work as consultants in Gangaram Hospital. Then there will be a talk by Dr. Raman Agarwal on decision-making and the treatment algorithm, followed by a session moderated by Dr. Shashank, on which all the panelists will be sitting. So I would set the ball rolling by requesting Dr. Ashish Acharya to begin his talk on injury pattern and clinical anatomy.
Thank you, Dr. Raju. Let me just share my screen. Yeah. Can you all see this?
Yeah,
my screen?
Yes.
Just put it on slide mode or play mode. And
Just
on the lower side.
No, not that one. I'm just looking to make it side.
Yeah, please move ahead, sir.
Okay. Good evening, everyone. As told by Dr. Raju, I'm Dr. Ashish Acharya. I'm at Gangaram Hospital. We will be dealing with the acromioclavicular joint, basically the clinical anatomy and the injury patterns. As we all know, the AC joint is a diarthrodial joint with the capsule, the interarticular synovium, cartilage, and the cartilage turns to a fibrocartilage as early as in the age of 17. So ACJ arthritis can be a very early phenomenon in younger patients also. Looking at the stabilizers, the static stabilizers, the AC ligaments, the superior, inferior, anterior, and posterior, the coracoclavicular ligaments, the conoid and the trapezoid. Coracoacromial ligaments are there, but they provide least importance in stability of the AC joint. The dynamic stabilizers are deltoid and trapezius. Among the AC ligaments, the superior ligament is more substantial and thicker. As per Steen et al., the range of insertion is 2.3 to 3.3 millimeter from the medial acromion, whereas from the lateral end of the clavicle, it is around 2.9 to 3.9 mm with a mean of 3.5 millimeter. Now, this has got significance while we are discussing about the lateral clavicle resection later on today. If we see at an article by Renfrey et al., they are saying from the distal end of the clavicle, this A in men is 0.8 to 1.8 millimeter, whereas in women it is almost like 2 millimeter, from 0 to 2 millimeter. And from the acromial side, it is 0.6 to 1.8 millimeter in men, while in females it is 1 to 2.9 millimeter. Average size for the joint surfaces in the adult acromioclavicular joint is vertically 9 millimeter and anteroposteriorly it is 19 millimeter. The average width of the joint is 1.1 to 3 millimeter, which usually decreases with advancing age regardless of the gender. The coracoclavicular space, as per Bidon et al., it is 1.1 to 1.3 centimeters. The distance has a clinical importance, particularly while differentiating between an incomplete or a complete ACJ separation. The larger the distance, the more complete the dislocation is. Salter et al. Has given the trapezoid and conoid ligaments to vary significantly in their length and width. The trapezoid ligament varied from 0.8 to 2.5 centimeters in both length and width, whereas the conoid ligament varied from 0.7 to 2.5 in length and 0.4 to 0.95 centimeters in width. If we calculate the center of the trapezoid and conoid ligament, it will be something around 2.5 and 4.6 centimeter from the lateral edge of the clavicle, as has been authenticated by various studies from various authors. Now, what are we looking at? If we go for a lateral clavicle resection, which will be talked on later on in this today only, if we resect 1 centimeter of the bone, we are almost detaching 97% or almost 100% of the capsule, along with the superior ligaments. And if we go beyond that, we are detaching not only the capsule and ligament, AC ligaments, we are also going for trapezoid and conoid ligaments, depending on how far we are going for the resection of the clavicle. And this will lead to the anteroposterior instability and postoperative pain, which will be a great problem. Coming to the biomechanics, with smaller displacements, the AC ligaments are the primary restraints for both posterior displacements. The conoid ligament was found to be a primary restraint to the superior translation, whereas the AC ligaments were still the primary restraint to the posterior translation. The trapezoid ligament was found to be the primary restraint to compression of the AC joint in both small and larger AC joint displacements. The mechanism of injury is basically the fall on the AC joint or directly on the shoulder with the limb by the side of the body. That is the adducted position. Happens very often in football, rugby, hockey, or karate. Indirect injury happens when you fall on an outspace and basically, when the humeral head is pushed up against the abdomen. Am I audible to you?
Yes, sir, you are audible, but your voice is fumbling actually a bit. Maybe because of...
Coming to the classification. Yeah, because internet connection or something like that.
Yeah, because of unstable internet connection there.
No issues. We are going through the classification. Dr. et al. Has actually divided into 6 types. Type 1, the AC ligaments are sprained. There is radiographically no widening, no separation or deformity of the AC joint. Type 2, where AC ligaments are torn, but the coracoclavicular ligaments are intact. A bilateral X-ray distal clavicle is slightly elevated, with the CC interspace is same in both injured and uninjured shoulder. Type 3, AC and CC ligaments both are torn. Deltoid and trapezial fascia are intact, and X-ray reveals a distal clavicle is 100% displaced superiorly in relation to the acromion. In type 4, in addition to the complete dislocation, there is a posterior displacement of the distal clavicle through the fascia of the trapezius.
Dr. Ashish, can you turn your video off since you're on a slightly low bandwidth? This might improve your audio.
Type 5. On a bilateral X-ray, there is almost like 100 to 300% increase in CC interspace. The deltotrapezoidal fascia is stripped off from the axilla.
Actually, it's still there.
I can. Do you want me to repeat from any slide, or do you want me to continue?
Please continue, Dr. Ashish.
Is it okay? Do you want me to continue from the previous slide or where?
Please continue to the next slide.
Problem
and
is
now
there?
the voice is better.
Okay, let me just begin from a slide prior. It's okay?
Perfect.
So type 3. Yeah. So let me first start with the type 3 again. It is the AC and the CC ligaments both are torn, and X-ray shows 100% displaced superiorly in relation to the acromion. The type 4, there is a complete dislocation with the posterior displacement of the distal clavicle through the fascia of the trapezius, as you can see here. In type 5, there is on a bilateral X-ray, there is a 100 to 300% increase in the CC interspace. The deltotrapezial fascia is stripped off from the acromion clavicle, and there is a greater degree of soft tissue damage. Type 6 is the inferior AC joint dislocation, either it is subacromial or subcoracoid. Thank you.
Thank you so much, Dr. Ashish. There was a little bit of minor audio glitches in the presentation, but overall, very nicely done. And if I can summarize your presentation, the key message that at least I got was be very frugal when you're doing the lateral clavicle resection. So I would like to invite any questions from the audience. I don't see any as yet in the chat box. Dr. Kapil has asked a question. Maybe I can pose it to you, Dr. Ashish. Dr. Kapil wants to know, is there a standardized view to measure the coracoclavicular distance? I suspect he's talking of radiology, and maybe Shashank will cover it in his next talk, but your views on that?
Yeah, I think yeah, there is. Zanka view is the most commonly approved. I think Dr. Shashank will elaborate on how to do those things. And he will be doing that. He's nodding his head right now, so he should be explaining us.
Since I don't see any further questions in the chat box, can I ask my panelists? Dr. Pandey wants to ask a question, and Dr. Prateek has also raised his hand. Dr. Pandey, we'll start with you first.
So, when you're doing an ACJ joint excision, how much clavicle can you excise? As per your slide, you said even if you excise 1 centimeter, you take away the entire capsule.
Almost, yes, sir.
So what is your recommended length or size of ACJ joint resection?
Sir, not my recommended. I would go by the studies that has been given to me. According to the studies.
That's what I meant. What does the literature say? Should you take out 1 centimeter, half a centimeter? Because clearly more than 1 centimeter will destabilize the ACJ.
Yes, sir. So according to Branch et al., it is 0.5 centimeter or 5 millimeter that is at best should be done. Maximum, and also in a study in 2003, which I have also quoted there, according to Boehm, it is 0.8 centimeter that you can maximum go for the lateral clavicle resection. If you are going beyond that, obviously you are damaging almost 97% of the capsule, as I have already cited in my article.
Correct. Dr. Prateek, you had something to add?
Dr. Nilesh, let Nilesh take this first, if you wish.
Just some food for thought, a comment actually. is that normally in an acute ACJ, we would anyways not excise the lateral end of clavicle. Most of us would not. We are talking about excision in a chronic etiology because you don't want ACJ arthrosis to set in. And in that scenario, anyways, the capsule is disrupted. So we really don't have a true capsule out there. So would it really be relevant to be worried about the attachment of the capsule, because the clavicle has already been in a dislocated position or a displaced position?
For ACJ joint arthritis.
Yeah, for arthritis and anyways arthroscopic, you're going from the undersurface, so you're keeping the superior AC intact.
Yes, sir. So that is what
the next the whole thing comes off.
Yeah, Nilesh, this thing I would be taking up in the excision. That's what Dr. Ashish was trying to say, that ACJ attachment starts on the clavicle side up from 3.9 millimeters. So if you go beyond 3.9 millimeters on clavicle side, you start removing the acromioclavicular ligament. And if you go beyond 5-6 millimeters, 7 millimeters or 9 millimeters, you almost taken off most of your AC joint, AC ligament on the clavicular side. So that can be a problem.
Correct. So I'll probably suggest that we move on to the next. And in summary, if we can maybe use a 4.5 millimeter shaver as the guide if we are doing an arthroscopic dissection, maybe that's a good point to start. Shashank, I see that your slides are ready. Would you please take on further?
Thank you, Raju, and thank you, Ashish, for making a couple of things easy for me. So we'll talk about clinical radiological correlation of the AC joint problems. And in the interest of time management, we are only going to talk about 3 common problems which we come across. There are many others, but we won't talk about them right now. Before we start on the problems, specific problems per se, as my topic and Prateek has specifically instructed me only to talk about clinical radiological assessment, I'm going to talk in 2 slides about clinical sign and radiological thing. So you must have heard of a lot of fancy tests for AC joint pathology, and by all means, you can do any of them. But in my practice, palpation of the AC joint and tenderness on palpation of AC joint is the most specific or pathognomic for me to identify the problem is coming from AC joint. The O'Brien's test, is, you all know, it's a little complicated. Piano sign is for AC joint injuries, but palpation and pain on palpation on the AC joint specific is very important for me. And this is how you do it. It's rather simple. You start here palpating from the medial end of the clavicle, go laterally towards the AC joint on both the sides. And as you reach both the AC joints, if the patient has pain on the affected side, then you can be rather sure that AC joint is partly or fully the cause of his problem. Investigation. There are many investigations, and you can do ultrasound, MRI, CT, and everything. But for me, again, for AC joint problems per se, X-rays are the most important thing. Which X-ray? You can have a simple chest X-ray. You can which is covering both the AC joints. You can have a Zanka view, both the shoulders. Or you can have the Zanka view with decreased exposure. In my view, in last 10-15 years, I started doing with Zanka view, and thanks to the inputs given by JM on the Dr. Maheshwari on this, I found that most of the times, by the time patient comes to me, they usually come with a chest X-ray like this. And a Zanka view with a 15-degree cephalic tilt. This is the actual Zanka view with the cephalic tilt and decreased exposure. Does not add much to my information in most of the cases. Yes, there is definitely some advantage of getting a Zanka view. You see less superimposition of the spine of the acromion by the clavicle. When you decrease the exposure, this joint is much more visible. There, you can see the cyst, the sclerosis, and everything else in the AC joint much more clearly in this. But if a simple chest X-ray like this is a simple chest X-ray, and all these X-rays were taken in my clinic, same patient, same place, same radiographer, same time. This was done with a 0 degree, and this was done with 15 degree cephalic tilt with decreased exposure. There's not much difference I could make out by doing all the fancy tricks of a Zanka view. So the point I'm trying to make here is that even if you have a simple chest X-ray with you, unless you can't see anything on it, then there is no need for a specific Zanka view for most of the pathologies. Minor sclerosis, cyst, yes, I understand, can be missed if in an improperly done chest AC joint view. So coming to the three problems I was talking about, most of you would know what osteolysis of the lateral clavicle is. Simply speaking, the lateral end of the clavicle starts melting away, starts disappearing. So there is an increased joint space in the AC joint on the affected side compared to the other side. It's a rather rare disease, seen mostly because of the repetitive injuries, either fall or people who in rugby, sports, wrestling in our country, weightlifters, or those, it can be a sequel of the old grade 1 or grade 2, quote unquote, innocent AC joint injuries, which later on can give rise to the osteolysis of the lateral clavicle. Usually it is painless, and most of the times it is found incidentally on a chest X-ray. Sometimes it can be painful. I would not go much in the treatment because Dr. Prateek is going to talk about it. But radiologically, X-ray is what is enough to diagnose this. You don't need any fancy MRI, etc. The osteoarthritis of the AC joint on the other end of the spectrum is the most common problem of AC joint, and the space is actually decreased in the AC joint in this. It is almost 60 to 70% present in people above 60. So all the shoulder MRIs you get done for rotator cuff tears or the quote unquote impingement, frozen shoulders and all of them will have some degree of AC joint arthritis in the MRI. It can also be there secondary to the injuries or the osteolysis of the lateral clavicle. But remember that it is present in most of us above the age of 60. At least the MRI signal or the white signal which is seen here is very commonly seen in most of the shoulders above 50, 55. Whether that is the problem or whether that is the cause of the patient's problem, that is something we need to look at, and there the palpation comes. So tenderness on palpation on the affected side, like this, as I just told you, is the most important sign for me to figure out whether the pain is coming from the AC joint or somewhere else. Some people do like to put a diagnostic injection. In my practice, I find it very, very difficult to put my needle inside that small space. Remember, a normal joint is about 2 to 3 mm width, and in arthritis, that width is further decreased. To put a needle there, I cannot do it. Less than 30% of times I have tried injecting, I've never felt that pop, which every textbook tries to describe, that the needle go through the capsule and you hear the pop. I've hardly ever heard it. You can try to do it if you reach the space. Very good. You're good. You can, but mind you, it's a very small joint. If you can inject more than 3 ml of fluid in that joint, that means you are not in the AC joint. So it's a very small joint. Hardly 1 or 2 ml of fluid can go inside. So make sure that what you're injecting is subcutaneous tissue or in the AC joint. You can do other tests too, and they are good. Cross-body adduction test, the second most common or specific test for me. for AC joint problems. This is an interesting article I came across just as a way of mentioning, where Funk et al. Found that the degree of symptoms or the severity of the symptoms in the acute setting in AC joint injuries does not correlate to the severity of injury. So you can have patients with very severe pain can still have grade 1 or 2 or type 1 or 2 type of AC joint problem. So don't think that a severely painful or severely restricted range of motion guy might be having a grade 4 or above AC joint problems.
Shashank, just to remind you, your time is up.
Oh, okay. Okay. So X-rays. I will just rush it up. Okay. So X-rays. Yes. I would not take this X-ray where only one side is taken. Not this, because both the AC joints are not clearly visible. What I would like is an X-ray like this, where both the AC joints are clearly visible, and I can see the clavicle and the acromion on both the sides rather clearly. Just last 3 slides, Raju, and then I will wrap up. To diagnose AC joint injuries is rather simple. Type 1 and 2 is very easy. There are clinical signs, pain, bruising, etc. Type 3 and 5 are simple too, because there is significant separation. However, there are 2 dilemmas which we face. And number 1 is differentiating 3 from 5. And the other is differentiating 3 from 4. As you would know that the 3 and 5, the difference is only the degree of displacement, whereas in 3, it is up to 100% displacement. And Kapil had asked a question regarding during the first talk. A simple X-ray where both the AC joints are visible with or without magnification will do the trick, because we are comparing the affected side from the non-affected side. And if the coracoclavicular distance is increased on the affected side more than 100%, I think that is good enough. I am not aware of any standardized view. A simple X-ray, a chest X-ray or a Zanka view with including both the AC joints is good enough for me. If there is a bump, a significant bump, if there is stenting and the X-rays show significant displacement, this goes more in favor of type 5. So good X-ray is a key to differentiate. To differentiate between 3 and 4 is well nigh difficult. Everybody has tried, many people have tried the axillary lateral view, the Alexander view, and so many other views, but it seems that even CT doesn't help. And the only thing that gives you some idea is if you ask the patient to come back for examination a few weeks later after the acute episode, and then you try to move the lateral in the clavicle. Just hold the lateral in the clavicle between the 2 fingers, stabilize the acromion with the other hand, and if you move it anteroposteriorly, that will give you some idea whether it is only vertical, that is 3 or 5, or there is a horizontal element 2, that is number 4. So to conclude, whenever you diagnose a grade 3 AC injury, please reconfirm whether you are dealing with 4 or 5. And I told you how. If in doubt, please document the need for repeat exam whenever the pain subsides. And usually within 2 to 3 weeks, AC joint ceases or the pain decreases substantially, and you can examine him again. Local tenderness in my books is the most specific indicator signifying AC joint pathology rather than the MRI or any other investigation. And MRI may over-report AC joint arthritis. Don't go by the MRI report. Lastly, most osteolysis are incidental findings. Most of them can be treated conservatively. I'm not going to the treatment, but don't worry about osteolysis if the patient does not have a significant problem or a clinical tenderness. Thank you.
Thank you so much, Shashank. I think you saved a lot of headache. Can you stop your screen share, Shashank, please?
Yeah.
So I think you saved a lot of headache for the orthopedic surgeon and the radiographer in that you don't need to remember any fancy names. But then Dr. Kapil mentioned one particular name, and I'll request him to speak about just a line about the Van Riet test, which he mentioned in the chat box, which has a 98% sensitivity. Dr. Kapil, please, can we have your views on that test? What exactly is the Van Riet test? I'm hearing it for the first time, honestly.
So it's a, can you hear me?
Yes, loud and clear.
Yeah. So the test is actually Bell-Van Riet test, which was described as Simon Bell and one of his fellows, Van Riet, and they published it in 2011. The reason I know it because one of my colleagues did a fellowship with Simon Bell, and Simon Bell has been to Aberdeen, and we were talking about this. So essentially, it's a combination of cross-arm adduction and O'Brien's test. So you put the patients across the body. You know, you do an O'Brien's test about here. If you take it, exaggerate that cross-arm adduction, and then you put downward pressure on it. If they've got tenderness or pain localized to the AC joint, they publish a 98% sensitivity for that test. I've not corroborated it clinically myself, but it seems logical because you're combining two stress tests onto the AC joint. So it just to mention for completion's sake that there is a test out there which is claimed to have high sensitivity, and maybe somebody can do a study to verify that.
Correct. So we'll have Raman's comments, but I remember something similar being mentioned in the O'Brien's test itself. I mean, the two arm positions, one is specific for the AC and one is specific for the biceps. Dr. Raman, your comments, please.
Yeah. I mean, in the O'Brien's test, if it is positive in the thumbs down position, then we go for a slap lesion. But if it is more positive in the thumbs up position, then AC joint is the culprit. And O'Brien's also describes doing the O'Brien's original test in 45 degrees of adduction and 10 degrees of adduction in two positions. So I think the Kapil is mentioning that 45 degrees adduction and then doing the O'Brien's. This is one. Second, I always do the Zanka views, and I'll tell you why. For me, it is important to look at the joint space and compare it on the opposite side. Of course, tenderness remains the cornerstone of clinical diagnosis and the relevance of it. But I need to compare the joint space of the AC joint on both sides if I'm suspecting an arthritis, which is symptomatic. So I need, that is why I need the Zanka view. I also need the Zanka view to see the full profile of the distal clavicle in DCO cases. And sorry, Shashank, I kind of disagree that they are incidental and asymptomatic. They are pretty common. Weight lift to shoulder is a pretty common entity, at least in my practice. Third thing, if I have to inject the AC joint, Zanka view does help me in identifying how to enter the AC joint because there are different slopes in the AC joint. And if you are entering at a wrong slope, then you will not enter the AC joint. So I need Zanka views for these three things. And I always do it bilaterally.
So point taken. Dr. Pandey, you have a point to make as well.
Yes, couple of things. When I do, we don't do Zanka view. We do only one shoulder, which is injured. But I also do either an axial or a strip view, which is a normal protocol we have with any shoulder X-ray. We take one AP and one axial or a strip view. The reason for doing that, you can get the grade force because that will show that the clavicle is displaced posteriorly. So that is one thing I always do. The other thing, I think an MRI scan is a pretty useful tool here. For me, if there is bone marrow edema around the arthritis, that patient is more likely to benefit from a excision because the arthritis is causing bone marrow edema. Also, it also shows spikes of inferior osteophyte, which is actually pressing into the rotator cuff. So I think, although I wouldn't do MRI scan as a routine for trauma, but if I'm doing it for an ACJ joint excision, there are two advantages. It tells you whether there is bone marrow edema. Secondly, whether there is inferior osteophyte. Thirdly, if there is a rotator cuff, it will show us anyway. So MRI scan has its place in ACJ joint pathology.
Okay. Point taken. I think it's time to move on to the Dr. Anand. Arya, you raised your hand, please. Your final comments.
Just a quick question to Shashank. What's your view about the weight bearing X-rays in the AC joint injuries?
I was going to cover that in the panel discussion before, but yes, in my practice, I stopped doing weight-bearing views. They don't have much place in my practice these days.
Correct. So can we move on to Dr. Raman's talk? Dr. Raman, who is in charge of shoulder service at Medicity, will be speaking on decision making and treatment algorithms for AC injuries. And can I request all the others to mute their windows?
Hi. So am I audible?
Yes.
Okay.
Screen is visible.
So first, the disclaimer. I've got a very limited experience in ACJ injuries, at least. I haven't done more than 15 to 20 operative cases of ACJ because I have been confused. I think I have improved in my thinking. I have done all sort of things, and I have moved away from most of the things and settled down on one thing. And we'll see why. So the questions we need to ask ourselves: what is the injury? Expectations of the patient, what is acute and what is chronic? Will surgery improve the outcome? If operating, when should we operate? Only CC ligaments or AC ligaments too? Open or arthroscopic, rigid or flexible, tunneling or encerclage, and finally, the autologous graft or the allograft if available. So, trying and understanding the injury, grade 1 and 2, let me just minimize this. Okay, grade 1 and 2 are kind of displacement of the clavicle is less than 100% of the distal clavicular diameter and CC distance increased to 20. Grade 3 is more than 100% diameter of the distal clavicle displaced and CC distance increases to 100%. Grade 4 is really posterior displacement. We don't know whether CC ligaments are completely or partially torn because the AC is torn, which is more responsible for horizontal instability. And that's why the clavicle goes posteriorly rather than going superiorly. So probably some degree of CC ligaments are retained. Type 5 is more than 300% of diameter of distal clavicle and around 300% of the CC distance. Type 6, I am really worried. I have sought out the whole literature. No series talks of type 6, not even one. I don't know why. Probably nobody has seen it. But yes, it is described inferior or the CC distance is reverse in this. So first 3 types talk of vertical displacement. Type 4 is actually posterior displacement. And these are dissociation of the upper limb from the fascia itself. So type 3 is a complete dislocation, vertical, no horizontal instability. Type 4 is actually irreducible posterior displacement, hence the surgery, indication for surgery. Type 5 is complete disruption of AC, CC ligaments and deltotrapezial fascia. The whole limb hangs down and it really is a question of suspending the upper limb under the clavicle when we are operating. So this is type 5, but are all type 5 equal? This is a patient, unfortunately, I don't have the clinical photograph of this patient, but I never thought this is type 5. Only on x-rays I thought it's type 5. Didn't look too bad clinically. So I did, this is my latest. So I have moved away from everything else and I just did an open reconstruction with tapes in an acute setting with tapes and encerclage around the coracoid and around the clavicle and I came out. But this is again type 5. And you can see the whole upper limb is suspended, is hanging down. And this is again the same X-ray. I mean, of course, Shashank mentioned tenting, bumping, but the distances seem okay, 300%, 300%, but both these type 5s are also not equal. So what we know, types 1 and 2, the conservative treatment, type 3 can be operated, should we operate, types 4 and 5 and 6, yes, we should operate. Now let's look at a little bit of literature, comparison of surgical and conservative treatment of Rockwood type 3. It's a meta-analysis published in Medicine in January 2018. 10 studies, 326 patients in surgical group and 323 in conservative group. The conclusions, higher incidence of CC ligament ossification and distal clavicular osteolysis in surgical group. No significant difference in terms of unsatisfactory functions. However, ACGI specific scores showed superiority of surgery. Surgical versus conservative interventions for treating ACG dislocation of the shoulder in adults. And now this is, Tamayuki has been doing a very sustained research on the ACG and He published a review, a Cochrane review in 2010, which he recently updated in October 2019. 5 randomized trials and 1 quasi-randomized trials. 357 patients, and here are the conclusions. Just a moment. Surgery may not improve function, return to work or sports, or quality of life at 1 year. Unclear whether there is a difference between surgery and conservative treatment in pain at 1 year, treatment failure leading to secondary surgery, and patient unhappiness with their shoulder appearance. More complications in the surgery group. So whatever you do, 15 to 20% of the patients are going to be dissatisfied, conservative or operative. Now, methods of fixation. Bosworth screw is largely abundant. K-wire is largely abundant because of dangerous complications. Hook plates are widely used. CC stabilization, arthroscopic or open, is widely used. CC plus AC stabilization, some people use it. And circular, some people are using it. Grafts, again, some we were done. Some have left it and some are still continuing. Now let us look at this. Arthroscopically assisted stabilization of acute high-grade ACJ. And this is a paper published by Marcus Schibel, 2011. 37 patients with type 5 dislocations operated within 18 days. Final CC distance was 13.6, which is way beyond the normal CC distance. So almost all had subluxated. 43% had horizontal instability finally, with significantly inferior results. So it was not a good result, although he mentioned satisfactory, but it was not a good result. So is CC stabilization alone sufficient for endoscopic treatment of severe ACJ dislocations? Barth et al. December 2015. Now this was a multi-center trial by the French Society for Arthroscopy. 14 centers and 22 surgeons participated. In 1 year, 116 patients operated within 21 days. And the conclusions were, anatomical reduction is a must for good functional outcome if you want to operate. Isolated CC stabilization, even with double endo button, is insufficient for lasting AC instability. CC plus AC stabilization definitely gives better outcome. Biological graft improves the outcome. Intra-op imaging failed to improve quality of reduction. This was quite surprising because I think I had definitely used the CM in the OT, but that was the conclusion of the French Society 2015. Another paper, open reduction and tunnel suspensory device fixation versus non-operating. We say that arthroscopy, oh, we may not have achieved the desired outcome, but let's go open and let us see the comparison of open. And this is an ACON prospective randomized trial published by the Edinburgh group, Michael Robinson again, and November 2018, 60 patients randomized for operative versus non-op, no difference in functional outcome at 1 year. 5 patients in non-op group not satisfied and went for surgical fixation. And have we missed the bus? If we have not operated in an acute period, have we missed the bus? So let's see what does, if we do surgery beyond 2 weeks, beyond 3 weeks, 4 weeks, in chronic cases, how does it fare well? So this was a systematic review published in Journal of Shoulder Elbow Surgery, July 2019, 27 studies, 590 patients, 3 groups. Group 1, non-biological or synthetic CC stabilization, had a 15% complication rate, failure rate was 8%. Group 2, biological, again, allograft or autograft, 15% complication and failure rate was again 7%. Group 3 was a Weaver done, 17% complication rate, failure rate 5%. So all were equal. Basically, there was no difference in 590 patients, whether you put grafts, whether you put synthetic material or you do a Weaver done.
Dr. Anand, just reminding you that you have ended the time limit.
This is my last slide. Early and second last slide. So early and delayed ACJ reconstruction provide equivalent outcomes, and Letterman has done some phenomenal work on the ACJ stabilization in encerclage, and he published in 2021, Journal of Shoulder Elbow Surgery, 20 patients per group. All patients had CC plus AC stabilization. Early group had CC plus AC. Late group had graceless allograft. Both groups had 3 subluxations and 6 dislocations each. Out of 20, 9 patients had complications. No difference in ACGI scores after 3 to 7 years. So late group had 4 complications. So all lettermen wanted to say whether you operate early or late doesn't matter. So do we have our decision making? At least mine has. What is the injury? Yes, we understand it now. Expectations of the patient are highly individual. What is acute chronic injury? Acute is definitely less than 2 weeks, preferably less than 10 days. Will surgery improve the outcome? In those who wish it. If operating, when should we operate? Does not matter. Only CC ligaments or AC ligaments? Both. Open arthroscopy or assisted? I have gone open, completely open. Rigid or flexible method? Flexible. Tunneling or encerclage? I have left tunneling. I have gone on to the encerclage. Autografts, if chronic, yes, I will definitely add it. Thank you.
Thank you very much, Dr. Raman. The last slide is indeed the crux of this entire presentation. Maybe the only thing which you have probably could have added, the recent paper in Journal of Shoulder and Elbow Surgery on double bundle reconstructions. I mean, double bundle in ACLs have gone out, but double bundles in CC ligament reconstructions seem to be.
I have looked at that paper, but because the time was only 8 minutes and I could only give an overview. But yes, the double bundle with the interference screw in the clavicle and then taking those tendon grafts to the AC seem to be working well. But yes, but again, and they didn't use tunneling in the coracoid.
Yes.
Tunneling in the clavicle is a different ball game because both are 1.5 centimeter apart. But tunneling in the coracoid, there is enlargement of the tunnel with the suture passage also, even if the latest tunnel diameter is 2.4, but it widens later on. So, yes.
Raju, can I ask you a question, Raju?
Yes, please.
Yeah, the point number 4, Raman, just keep the slide on. Point number 4, will surgery improve the outcome? That is the very crucial question. And the answer is in those who wish it. I don't understand what it means.
Okay. So if I go by the literature and whatever I have learned, I tell the patients, obviously the gross deformity in type 5 will make you and the patients think aligned. They will be aligned. Yes, patient also knows it's a gross deformity. We need to get it sorted. I'm talking about 3 and 4. In 3 and 4, the patient, you have to be counseling the patient, yes, what we need to do. And I tell the patient, yes, the time, basically the decision making has to be done in terms of time frame. If you operate within 10 days or a maximum 2 weeks, only then the ligament will heal. If we are not doing that, then we are falling back upon a graft. Then I have to take a graft from the knee as well. And final outcome, infections and hardware complications are more in the operative group. So in type 3 and type 4, I would want to tell the patient, look, there is no difference. Spend 2 months, 3 months in the rehab. If you still feel, come back and we'll do it for you. That is what in those who wish it. If the patient comes willingly, then patient will accept the complication as well. Or the discomfort as well.
For a collision athlete, for example, you treat a fair amount of wrestlers and kabaddi players. In a collision athlete, would your answer be still the same for a type 3 dislocation or a type 4?
No, in a coalition athlete in type 3, yes, but my answer will still be very guarded. I mean, we operate highly demanding athletes in type 3. And those guys, if they are not educated well enough, they give due importance to their cosmetic appearance, like bodybuilding. In cosmetic appearance, almost all surgeries have a failure rate. If I have touched the patient, it is a more dissatisfaction. But if I tell the patient I have not operated, this is still going to be 50% reduced. Late recurrence is quite known in all methods, even hook plates, 12% failure rate in hook plates. So if the patient accepts that and he comes back to me later on, he will not come for the cosmetic appearance, he will come for the functional deficit. This is what I want to say, that if patient understands and he wants the surgery, fully understanding what can go wrong and what can be the final outcome, in those surgery will improve the outcome.
Someone, can you please stop your screen share so that we can see the entire panel? And can I also request the host to let Dr. Gurinder Bedi in? I think he is in the other window. And maybe Shashank, if you can set up the panel discussion, if you want to do it through a PPT, and we can just take one question as you are setting up your laptop.
So,
Dr. Prateek, please.
Yeah. there's a question and comment both. As there was talk about, Shashank said that, you do see osteolysis of lateral clavicle and do not get worried. It may be asymptomatic. That is not true most of the time, because when we see weightlifters, they have problem, and sometimes it is difficult to ascertain whether it is a problem or not. So if the MRI shows edema, and which edema is only on one side of the joint of ACJ, that means on the clavicle lateral line, then that signifies that there is osteolysis and the pathology is there. So that sometimes has helped me to ascertain this is symptomatic osteolysis causing the problem.
Correct. So Shashank, can I request you to introduce your panel, and please note that we are at 5 o'clock at the time in which the panel discussion was supposed to end. So maybe if you can just keep your questions sharp and answers incisive from the panelists, it will help us in time management.
Actually, Raju, most of the questions which I kept in panel discussion have already been asked. So maybe it will be actually shorter than you think. If Prateek or you tell me, we can. Most of them have been covered. We can actually junk it and go to the next topic.
No, please, let's do it. I'm sure there would be 1 or 2 questions which have not been covered, and we can
So the first question was about the significance of Zanka view, and I think Dr. Pandey and Dr. Kapil have already talked about it. How many? I wanted to know about from the. Are all the panelists here? Do we have Dr. Arya, Shekhar, Raman, Dr. Basin is here with me, and Dr. Prateek. Is everybody here? Yeah. So how many people routinely do Zanka views in their clinical practice when they face the AC joint problem patient? We will start with Dr. Anand Arya.
No, I don't.
You don't do Zanka. Okay. Shekhar?
No, I don't do it.
Raman?
I always do
said yes. You already said yes.
I always do it in bilateral. Always.
Okay. Yeah. So I'm presuming Zanka view is bilateral. Yeah. Okay. Dr. Basim?
Not as a routine, but specifically I am suspecting an AC joint.
Yes, and
then yes.
Okay, Prateek?
Yeah, I routinely do both sides, Zenka, whenever I have to see the AC joint properly.
Raju?
I do it, but after hearing your talk and seeing those slides, I think I'll probably spare the radiographer the headache.
Okay, so that's what I used to do too, and it's only for this talk. I had one Bristol patient who was just there a couple of days back in the clinic, and I asked him if I can take a few more X-rays, and he said okay. And I actually found not much difference in the Zanka view compared to the regular chest AP with both the. I invite other people to, if they have a chance in their patients where they already have a chest with both AC joints, and compare that with the Zanka view if their hospital protocol permits, to see what exactly is the extra knowledge you get with Zanka view. Sorry, somebody spoke?
So Shashank, not in panel, am I permitted to comment?
Oh, please. Nobody can stop you.
Yeah, I suppose. So my question is, first message you should send across to the audience, a lot of them are general orthopedic surgeons, all these X-rays have to be done with patient standing and not lying down. Right. In fact, all shoulder X-rays have to be done with the patient standing, number one. Number two is, when you do chest X-ray, you are actually hugging the plate. So I don't think that is equal to a AC joint X-ray on both sides, where the weight of the limb is distracting. And that's what you are very critically interested in. Even if you do an AP, including both AC joint, the limb has to be hanging and not chest X-ray. I don't think that is the right thing to do, because chest X-ray, you hug the plate. And third is
wait a minute, sorry. Chest, you're talking about the PA view. But
yeah.
When we do a AC joint, for AC joints, we don't do it a PA view. We just stand against the plate, and it's a simple AP view which we take the whole of chest.
Good that you clarified that, because chest X-ray means a PA view for a normal person.
Okay,
that's very good. Now, third point I want to make is that standard is, a person has a shoulder injury, he gets an AP view done. If it is type 3, 4, 5, where is the need to do any other X-ray? I agree with Pandey. Why do you want to do another X-ray or Zanka view or whatever? You do those views only when on a standard AP view you have a doubt, like maybe type 1, type 2, type 3 at the most. Otherwise, why should you do another X-ray? I mean, that's my question.
So, to answer your question, how will you differentiate between 3 and 5 if you don't have the opposite AC joint view?
Can I just come in for a second?
Yes, Kapil, please.
Yeah, I put this comment in the chat earlier on as well. I've heard most of you saying that you do bilateral views, you do this. The crux of the matter is in how many of your patients, what percentage of patients does your management decision change after doing both shoulder, both AC joint X-rays? How does it alter your management? Whether it's a type 3, type 5, you're going to go and look at it clinically, you're going to look at patients' deformity and function, and that allows you to make a decision. In how many patients doing both shoulder X-rays has it changed your management? For me, it doesn't do anything, and that is why we've all moved over from the stress radiographs as well, because they were not contributing anything. So just if you can do a quick survey, I think if you stop screen sharing, you might be able to see everyone, and then do a quick survey. How many people's management changes with both X-rays?
Raju, this time is not included in my panel discussion. Okay, Kapil, go ahead.
Kapil, I do the both sides X-ray if I'm doubtful about the magnitude or type of injury. If I'm clear, so it is say a grade 4 or 5 or 6, then there is no need for it. Grade 1, there is no need for it. But normally in grade 2 or 3, it's beneficial to do the other side just to give it a bit more information about, what grade the injury is. And then you can have a better discussion with the patient about operative or non-operative. So only those limited situations, I do the both sides.
Yeah, that is what I'm just being the devil's advocate here. But in how many of those patients where you're not sure about the extent of injury and you're having to do 2 X-rays, are you going to go and operate on them in the first instance? You're not. So it has not changed your management. That is the point.
No, it's not. It's not like that, because
there's a bias in that question, because type 4, 5 are actually very rare. So if you ask how many times your decision has changed, if you don't get 4, 5, 6 so often, so the decision of changing your treatment may not be that much, because 4, 5, 6 are anyway very rare. But you need to know, and you need to tell the patient whether it is it's a type 5 or a type 3, because till type 3. I haven't operated as yet in acute injuries. But if there's a type 5, I will tell my patient more forcefully that yes, you need surgery.
I'll stop speaking because it just eats into your time. So, but we'll probably agree to disagree on this one and stop it there.
Sure.
I think Dr. Pandey and Dr. Maheshwari want to say something. There's a hand raised there.
My question is related. Shashank, you said type 3 and 5 possibly can be distinguished if you take 2 X-rays of both sides. And if you believe that type 5 should be operated and type 3 I'm conservative, then yes, you take X-rays of both sides and it might just help you to shift from 3 to 5. And since you believe type 5 should be operated, that may be a fair justification. But my question on the chat box is, does everybody, we'll come to that later.
Dr. Pandey, you want to say something? Can you unmute yourself, please?
Sorry, I raised my hand for a previous problem, but I think it's an important point I would like to raise about the osteolysis of the lateral end of the clavicle. I think osteolysis anywhere in the body should not be taken lightly. It needs to be, I've had only one experience of a chondrosarcoma, which we picked up because of a slight osteolysis over the lateral end of clavicle. So I think if there is osteolysis of the lateral end of clavicle, it should be at least taken a bit more seriously and not be said that it is not a problem.
So that's very interesting, Dr. Pandey. So if you see osteolysis of the lateral end of clavicle, do you subject these patients to MRI? What do you do? What do you do next?
So yeah, sometimes I will. If it's a young patient, I will examine it seriously. And
most of the osteolysis I have seen are usually in younger patients, less than 40, around 40, yeah, isn't it?
Yeah. So I don't have any. I do not have a hesitation in doing an MRI scan in them.
Oh, that's it. Okay. So that is a okay. 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 So coming to this Zanka view with weights, in my practice, I have stopped doing weights, using weights for Zanka view at all. Does anybody differ with me? Please raise your hand and put your point. Otherwise, we'll go on to the next one.
I think let's move on, Shashank. We are obviously hard pressed for time.
Okay. Okay. We have already MRI. I think we've already, Doctor.
If you can cover just one more incisive topic which you feel hasn't been addressed adequately, it will be great.
I think everything else has been. I would just like to ask one thing: how do people in this panel rule out posterior displacement or instability in acute cases? So we'll start with Kapil. Kapil wants to say something, it seems.
I clinically and two views, AP and axillary view.
Axillary view show, because all that time I have seen axillary view, usually there is so much of overlap, you can't make out much, because unless there is a very significant posterior displacement of the clavicle, the overlap is so much you can't make it out. Have you faced that? No.
We use a strip view, something called a strip view.
Yeah. Okay.
Because the patient after acute injury may not be able to abduct the shoulder to 90 degrees. So
anybody has a different opinion, or can I go to the next one, last one?
I think in our hospital's protocol, the CT scan is pretty sort of routine for all these kind of injuries there. Okay. So a 3D of CT scan should be able to differentiate the posterior dislocation quite easily. So we normally, if there's any doubt, just get a CT scan done.
So that's what I used to think, and I went to search literature how to look for a posterior displacement, and I quoted that a couple of articles in my talk. Most of them say that axillary view or CT scan don't help in posterior displacement. One of the reasons why CT scan doesn't help is when the patient is lying down, the posterior displacement corrects or reduces itself because of the weight of the limb. The posterior displacement of the clavicle reduces itself, and there is no the scapula falls down and it starts articulating with the lateral clavicle. So I was wondering, and me and Dr. Jain Maheshwari was talking about this a couple of months back. Has anybody thought of doing a prone CT scan in these patients to discover posterior displacement of clavicle where you're suspecting? Do you think prone CT scan will help? I will start with Dr. Pandey.
Well, never thought of it. I mean, I can only guess. It's probably, I don't know whether it can be done.
Yes, I already asked my radiologist, and he said yes, it can be done. There is not issue. But for last 1.5 years, I'm looking for a patient with a suspected posterior displacement. I haven't got any.
Well, I will show you a slide, but I think if you have a reasonable axillary or strip view, I can't see a problem. But I'm sorry, Shashank, I've never done a prone CT.
No, I know nobody would have done it, but do you think it makes sense, Kapil?
Shashank, I come to the same thing. If that displacement is so subtle that you're unable to pick it up on other imaging tools, how does a prone CT help your management? How does it change your management? My idea of doing an investigation is, does it change what you're going to do? If it does not,
let's say we presume that 4 and above need surgical treatment. I know there can be a controversy there too, but let's presume for a moment that 4+ types, 4, 5, 6 need surgery. So I need to know whether this is 4 or not. There's a posterior displacement. The lateral clavicle has gone into the trapezial fascia and it won't reduce on its own. So to know that whether this patient needs surgery, I would like to know whether there's a posterior displacement.
Shashank, can I just divert your attention to a slightly low-tech question, which may be practically relevant? An attendee has asked us, does any particular bracing technique that you would like to recommend? Does the panel like to recommend any particular bracing technique for a lower grade injury? Or a simple cuff and collar?
Nothing works for the patient. It only gives you some little extra money. That's it.
So regarding prone lying CT, this is one of those crazy ideas me and Shashank get when we have had one beer each.
Shashank,
Yes.
how do you know that a grade 4 dislocation which has gone through the posterior trapezial fascia would reduce on lying supine?
That's what literature says.
Where does it say that?
I can send you. I have those.
Please do that, because I don't think it will actually reduce, because it is the buttonholing of the lateral end of clavicle through the trapezial fascia. By definition, grade 4 is irreducible posterior dislocation.
I agree.
Exactly.
Raman.
That's what I wanted to say. I totally agree with the Raman that the grade 4 means irreducible posterior displacement.
It will not reduce on lying supine.
So it doesn't matter whether you take the CT in supine or the prone position. If it gets reduced by itself, then it's not grade 4.
Yeah. I think in the interest of time, sir, let's move on with the last comment from Dr. Bhasin, sir.
Yeah, if it is a standing CT, then probably yes, because it is the weight of the arm which takes it. Actually, it's not the clavicle which has gone up or back. It is the arm which has moved forward and lower. So if it is standing, it will show. But prone, I have my doubt that prone CT will make any difference. So if it is something in standing position, yes.
Okay. So I'd like to conclude this session with Dr. Prateek's permission. I think it's been a very interesting session, and the panel discussion particularly had some interesting key messages. Would like to invite Dr. Gurinder Bedi to take over the next session as the moderator and to invite his panelists and speakers henceforth. Thank you very much.
Thank you, Raju. I wish to invite Dr. Gurinder Bedi. Dr. Gurinder Bedi, just a small introduction, is orthopedic surgeon who heads Department of Orthopaedic. He's a director as well as head of Department of Orthopaedics and Sports Sciences at Vasant Kunj facility of Fortis. And he's kindly agreed to moderate the next session. I invite him to take over. Gurinder, please start.
Perfect. Thank you so much. Thank you so much, Prateek, and thank you so much for having me over. Always fun coming back to this meeting. So we got a galaxy of speakers in the next meeting. We also have a hell of a lot of panelists, and all of them are the who's who of shoulder surgery across India. It's a fairly interesting session. I think most orthopedic surgeons will love it because it's got a lot of operative work. So we've got about 7 of these speakers who are going to tell us about a single method of fixation which they use for AC joints. We'll follow that up with 2 or 3 questions which the panelists can ask, or the different delegates who there can actually put in the questions, just like we've been doing it before in the chat box. And I'll be happy to take the questions over and get them answered either from the faculty first or the panelists in this. So my first speaker for the day is Nilesh. Nilesh, I think a lot of you would remember from the Pune knee course, works in Pune in the Jahangir Hospital. So he's going to talk about possibly the much more common method of fixation, which is a suture and button fixation of acute ACJ injuries. Nilesh, can you take it from here, please?
Right, thank you so much, Dr. Bedi. So I'll start off with my screen share, and if you could just validate that my slides are being seen.
That's it. We're on, Nilesh.
Right. So at the outset, I would like to thank Dr. Prateek for his invitation, and all of us know this is a relatively uncommon spoken about topic, and it's quite controversial. My relevant financial disclosures, I'm a paid consultant for Arthrex and Smith Nephew for their fellowships and teaching programs. So it's interesting that if you look at literature, nearly 50 years back, this statement was what came across the panel. Seldom do 2 orthopedic surgeons agree on the precise management of a complete AC joint dislocation. And nearly half a century down the line, we're still pretty much stuck up there because we still haven't found the holy grail. We have had previous talks on anatomy, so I'm simply going to skip this across. But what we need to understand is that when we are looking at using buttons for fixation, we're trying to restore the vertical stability primarily, and that's restoring your coracoclavicular ligaments. The Rockwood classification hasn't spoken about, but what was not discussed is that this is purely a radiological classification. So there was no clinical aspect which was brought into picture. And that is the reason why the ISACOS group, the upper limb committee, met across in 2015 to come across with this recommendation. And we had so much of discussion on imaging in the prior session. And what they have recommended is that 4 sets of views are required. I'll submit to you that I don't routinely do all these views, but these are the recommendations: that you need a true AP, you need a Zanka view, you need an axillary lateral, and you need a cross-arm adduction view. Now, why is this important? Is because, again, although we know that type 1, type 2, conservative, 4, 5, 6, operative, 3, controversial, but it's the type 3 which needs to be subdivided either as 3A or 3B. And that is where the ISACOS group came in with the fact that if there is a posterior translation on the type 3 dislocations, these are the ones who tend to be more unstable. These are the ones who will become more symptomatic eventually. And as a result of which, it is important to see to it that a lot of scapulothoracic articulation and rehab is brought about in these patients before really offering them any surgery. So we know multiple modalities of fixation of AC joint, and none of them have really stood the test of time. But we are here to talk about something which has probably picked up pace in the last few years. We don't know 10 years from now whether this will still hold good. But as I mentioned, the rationale here is to create a transosseous tunnel across the superior and inferior cortices of your clavicle, which passes across the base of the coracoid. Using a cannulated drill, it allows to shuttle across a nitinol loop, which is then retrieved through the anterior-inferior portal. I do these routinely arthroscopically, but you can very well do them as an open technique. Through this nitinol loop, that's when you're going to bring about your sutures or your tapes. And I routinely use tapes, not just sutures, with a button and not just an endo button. I would prefer to use a dog bone button. And that's primarily because you're transmitting the forces across a wider area rather than creating point contact, which is going to increase your pressure along the clavicle, resulting in tunnel fractures or tunnel widening eventually. Why arthroscopic fixation? Professor Imhoff has shown that there's nearly an 18%, and some papers recently have spoken nearly a 25 to 30% of concomitant intra-articular injuries. And that's more so when you're looking at type 5 injuries. Probably a type 3 may not have an associated intra-articular injury as a routine injury. So we do this in a beach chair position. That's a type 5 dislocation. With a beach chair position, after a diagnostic round, the first thing that you would want to do is create a lateral or a high lateral portal parallel to the fibers of subscap. So those who don't do arthroscopy, for them an orientation, right side is your humeral head, left side is your glenoid. The horizontal structure is your subscapularis tendon, and at 1 o'clock, 2 o'clock position is the long head of biceps. You bring across your radio frequency wand and start clearing the rotator interval. We are all aware that the base of the rotator interval is formed by the coracoid. Once you start seeing the coracoid, gradually you're going to reorient yourself to such a manner that all the attachments of the coracoid are properly visible. So again, that's the tip of the coracoid. That's the conjoint tendon at the tip of the coracoid. On the lateral aspect, you have the CA ligament, and on the medial aspect, you have the pec minor. Once you have this orientation, you can't really visualize the coracoid beyond that. That's when your anterior-inferior portal comes in, which is lateral to the coracoid. You may or may not use a cannula, but if you're using one, you need to use a 8.25 cannula. And then you're going to switch your viewing from the anterior-superior portal. From here, you can see the posterior aspect is where the Wissenger rod is coming in. Anterior-inferior portal is where the probe is coming in. That's where I'm probing the tendon of subscapularis, and you can see the coracoid coming from lateral on through to medial. So that's your genu of the coracoid, which is the junction between the horizontal and the vertical part. And it is at this genu, that's where you would want the desired site of drilling for your cannulated drill. Using the commercially available guide system, which is pretty versatile, you can actually get in a cannulated drill in to come in right at the base of the coracoid. And it's very important to see that you have a bone bridge both on the medial side as well as the lateral side. Because if you don't have so, and as you're retrieving your loops, it is possible that your button can actually fracture in through the lateral cortex or the medial cortex of the coracoid and come to lie in the subacromial space. After the nitinol loop is put across, a preloaded dog bone button with your fiber tapes is then shuttled across. It is very important to see fixation or seating of this button on the undersurface of the coracoid. So do not just pull at it, but try to milk it and try to maneuver it with your grabber in such a manner that it sits flush in the horizontal position right across the base of the coracoid. Once that is done, you may use fluoroscopic guidance to assess for reduction, because in some patients, and the reason why I use fluoroscopy is because in some patients there is soft tissue interposition, and I burnt my fingers earlier where I thought that the reduction was good, and in the post-op X-ray it did not really look satisfactory. Then attention is brought onto the superior surface, and the second button is then brought on the superior surface, and the tapes are then tied across. The disadvantage is that these knots are quite bulky, so you need to do a closure in a sequential manner so that the knots are buried under the fascia. Otherwise, they cause prominence for the patient and discomfort. That's the post-op reduction, and that's your arthroscopic portals being closed, and that's the final post-op X-ray in the ward. In the post-op protocol, I usually ask them to use a sling for 2 to 3 weeks. Once the pain control is better, simultaneously knees phase 1 exercises are started. Closed chain range of motion exercises primarily to prevent an anterior capsular contracture is started. And then gradually over the next 12 weeks, we bring them on to full range of motion. The same patient with a grade 5, and at 8 weeks, he has fairly good range of motion. But everything comes with their own set of complications. So they had the study at the Stedman Clinic where they assessed the results of suture with your cortical button fixation. And what they found was that there was an overall complication rate of 27%, which is significant for any operative procedure. The survivorship at 12 years was calculated to be at around 86%, and at 24 months was at around 83%. But we know that if you're using an associated autograft, that can also cause tunnel widening. And that's probably one of the reasons where Dr. Raman mentioned earlier that he would like to just prevent drilling tunnels as much as possible, which does make sense because we know from our knowledge of ACLs, PCLs that all soft tissue grafts tend to cause some amount of widening in the bone. So if you looked at the advantages, so if I have to summarize for their advantages and disadvantages, with these cortical buttons, especially if you do them arthroscopic, it's minimally invasive with good short-term to mid-term results. It allows you to address concomitant intra-articular pathologies. There is no need for revision surgery, and there is minimal metalwork in situ, causing less morbidity. However, there's a steep learning curve. It is expensive, which has its bearing, especially in the Indian setup, because not every patient is affording enough to use all these branded dog bone buttons and tapes. Long-term outcomes are still needed. Another flip side to it is that there is no provision for horizontal stability. So with so much of debate about how do you want to see whether there's a posterior translation, and the fact still remains, and that's where I would completely agree with Dr. Kapil, that how is it going to change your management? Even if you know that there is some amount of posterior translation, because one maneuver that I do when I bring about the reduction is that I put in a small bone lever on the posterior cortex of the clavicle and try to translate it anteriorly. So if at all there is any kind of posterior translation, that is going to at least reduce or is going to correct itself. And lastly, because it's a transosseous technique, there is a risk of fracture in the elderly and in osteoporotic patients. Thank you.
Thank you so much, Nilesh. That was absolutely wonderful. The video was very, very good. Just one quick question. I think I'm going to take one question which Raju has put up. And the question is about the intra-articular injuries. How often, Nilesh, I mean, I'm totally with you. Nobody's done enough. I was just discussing with Raman, nobody has done too many to sort of be an expert on it. But what is the incidence of intra-articular pathologies that you actually pick up in your practice, and what have you done about it?
All right, so we have done probably around 18 of these cases over the last 5 years. And what I have seen is thrice, as of now, thrice I have had to do a single anchor along the posterior superior labrum because the biceps, a typical 2C type of slap tear was what was there, where the biceps had actually peeled off. That's the only repair that I have done. I've never had to do a cuff repair or an anterior labral tear, anything on those lines. But all these 3 cases, it was a very typical pattern, one single anchor. That was what was used.
So this was an acute injury, which you could make out was an acute injury that had happened.
Right, right.
Raman.
So Nilesh, of course, as usual, great presentation, great skills. Just one question. I did 7 of these dog buttons, all arthroscopic. Yes. Then I stopped. I had 3 complications. Okay. Well, fortunate or unfortunate, I had them early. I had 1 coracoid fracture, and I had 2 late failures.
Raman, can you take the screen? Sorry, Anand, can you take the screen while Raman is asking? Sorry, Raman, sorry. Carry on.
So that's the thing. What was your complication rate of 18 cases in 5 years?
Fortunately, I've not had a single fracture. Not a single fracture. Yes, I've had delayed loss of reduction. So I've had around 4 patients where from a type 5, they have come to a type, I wouldn't say classical type 3, but they have come to a type 2 where partly the articulation is off. But patients have been asymptomatic about it. So I've really
that I agree. My 2 failures, late failures, not late, they happened within 6 weeks. And patients are okay. So now they've again converted to type 3 and patients are okay. Full range of movement, doing great 5 therabands. That again brings back me the question. Even type 4 can do a very well thing without complications. Just playing the devil's advocate.
So, we really don't know as to where are we going in the future, because we had Professor E.G. Itoy, who had attended as the chief faculty at the Pune Shoulder Course 2 years back.
Yeah, I was there. I was there with you guys.
You were there then, right? And then when we were discussing with him, he was of the opinion that he would never ever operate any AC joint.
Yes.
Because his belief is whatever you do for the AC joint, results are suboptimal. Of course, that's an individual thought process. But what I'm saying is even from the greats, you have the opinion where we still don't have a consensus on this.
No, we don't actually. Consensus is emerging gradually. We become wiser day by day.
Can I, Anand, can I request you? Anand is a good friend. I think Anand, you're from, we lectured on the Rajasthan Orthopaedics. So I take it you graduated from there, but welcome. Welcome. I think most of people know that you're working in King's College in London. You have a special interest in shoulder and upper limb surgery. So you picking on a very controversial thing. I can tell you, you better get ready to be fired upon. You're going to get a full barrage of things. So we want a lot of discussion on this, Anand. So snappy presentation, please.
That's the beauty of orthopedics.
Wonderful.
Many different ways of solving a problem, and everyone is right in their own place.
Yes.
So thanks, Prateek, for inviting me. It gets such a good feeling to be amongst the friends there. So as we all know that I've included type 3 here, but certainly type 4 to 6 need surgical stabilization. And there are many different methods of doing that. Unfortunately, there is no gold standard for it. And whenever a problem has many different solutions, that usually means that none of the solution is perfect. And same is true for the ACJ dislocations. Hook plate is one of the earlier and time-tested method for it. So the clavicular hook plate is first marketed by Synthes. It's a pre-contoured plate. I think it came to the market around 20 years ago. So it has got a hook at one end and a plate is there. It's separate for left and right side, comes in different lengths and the different depth of the hook there. And the hook is kept behind the AC joint, posteriorly under the surface of the acromion. And the plate is fixed to the clavicle. And the manufacturers recommend the routine removal of this plate after 3 to 4 months because of the possible complications of the impingement or the acromion osteolysis. The operation is done in the beach chair position. You can use either a horizontal incision along the line of clavicle or a vertical incision right angle to it. And this incision is more useful, especially if you're planning to repair the coracoclavicular ligament also at the same time. So after the exposure, the AC joint is cleared of the debris. And then some people do a temporary fixation with K-wire. I don't do that. And you select the right plate and create a space for the hook to enter. So just split the soft tissues behind the ACJ, put the hook under the posterior acromion, and then hold the plate with a clamp along with the clavicle. And at that point, an image intensifier should be used to make sure that the ACJ is fully reduced. And at the same time, the shoulder can be moved, especially the abduction and internal rotation, and there is no impingement of the humeral head over the hook there. And once you're satisfied with that, then the plate can be screwed to the clavicle. Quite often, the medial end of the plate would be lifted up. So you might have to contour it a little bit to put it flush to the clavicle. And the post-operatively, the arm is put it in a sling, and the movements can be started quite early, say within 1 to 2 weeks time, starting from the passive and the active assisted movements. It is logical to assume that there would be some terminal restriction of the abduction and internal rotation by this plate. But once the plate is removed, then those problems should go. There is always a theoretical description of the complications such as impingement, rotator cuff problems, and the osteolysis. This is an extreme example of the osteolysis, but there is a very little mention in the literature about it. People hardly have shown any examples of that. There is some chance of the implant failure, the screw becomes loose, but that is like any other internal fixation. The plate need to be removed after 3 to 4 months time, and this requires a second operation, which probably remains the main downside of this implant. This is one of my patient, which is on the left side X-rays 3 months after surgery, and on the right side is 12 months after removal of the plate. There is a plenty of articles in the literature about the hook plate because it is such a widely used implant. This particular study had a 4.2 years of average follow-up, and the patient's hair were able to gain the full range of movement at 5 weeks and start their sporting activities at the week 6. And there was no complications and good to excellent functional outcome. There is another recent study, which is a cadaveric study, and they studied the biomechanics of the hook plate and showed that it has supraphysiological mechanical strength, does not cause any bony impingement, and can exhibit rotator cuff impingement, but only with maximal abduction and forward flexion there. Some people think that along with the hook plate, one should also repair the coracoclavicular ligament. There is no consensus about it. In this particular study of a prospective series of 33 active military personnel, a hook plate was applied without the CC ligament reconstruction. It had a good 2 years follow-up, and everyone went back to their hard military jobs, which would put a lot of stress on their shoulder and the ACJ. None of the patient has any complications or the pain, and a full range of movement with a good outcome score. The another study here, which is a comparative study of the hook plate with or without coracoclavicular ligament suture. And it's a large series of 120 patients and equally divided into 2 groups, grade 3 to 5 dislocations and minimal 1 year follow-up. This study concluded that the CC ligament repair along with the hook plate is better for maintenance of coracoclavicular distance and maintenance of reduction of the ACJ, but there was no difference in the clinical outcome and complication between the 2 groups. There are a lot of reports of the meta-analysis between the treatment of the ACJ by hook plate and the another group of suspensory loop fixation devices, of which the dog button and the bony anchors and the tightrope, they are sort of some examples there. The quality of these studies are quite variable, and because of a lot of selection bias and the variability of the outcome measures as well as the small numbers. But most of these studies agree that although there is no difference in the functional outcome of treatment of ACJ dislocation, by hook plate or any of the suspensory devices, but the tight rope certainly gives better relief of post-operative pain in the beginning, although it carries slightly increased rate of complications, and technically it is more challenging. While hook plate is a quick and simple technique, short learning curve, and less complications. So my take on this, that I still, I do the hook plate for a long time. I still prefer it because I think it's a safe, simple, effective, and reliable implant. It's a quick and easy technique with a short learning curve. People can do it quite, with sort of little training there. It's relatively inexpensive. And as the point was mentioned earlier, the hook plate stabilizes the ACJ in both a vertical as well as anterior posterior plane. And these suspensory devices, there is always a doubt whether they are able to stabilize the joint into the anterior posterior plane. There is a quick recovery of function after that. And certainly the downside of the hook plate is that you normally require a second operation for removal of plate. And I feel that this is the price worth paying for a reliable and predictable, simple operation. Thank you very much.
Thank you so much. That was absolutely wonderful. You do put forward a very good argument. You missed out that Canadian Orthopaedic Association study, which was a fairly decent study, which looked at hook plate versus no treatment at all in grade 3 injuries. Can I invite questions in this, please? Any questions? Any people who are using it more or have used it and have changed over or would like to start using it? Prateek?
Yeah, Anand. What did you find out? What is your experience with the erosion? We have used a few, and the undersurface of the acromion erosion. And in one patient, there was little rotator cuff impingement also by the time the patient got off the plate. So how common is it, or is it something which is within the limits according to your experience, because you've been using it more?
Thanks, Prateek. I mean, I would understand that erosion is a gradual process, and that would only happen if there is a constant and a significant pressure on the undersurface of acromion. And one problem the erosion can happen is that if you use a shorter depth of the hook, so if you feel that hook is very tight, and then the another one option is that you use slightly deeper hook. So Synthes has two sizes of the hooks, 15 and 18 millimeter. I'm sure other manufacturers may have different sizes there. So if you feel that it is too tight, then use a larger depth hook there. And if you remove the plate at sort of, between 3 and 6 months time, then it is difficult to understand why there should be any erosion there. But I agree that till the plate is there, there would be some pain and discomfort on the terminal range of the abduction and internal rotation.
Raman and Kapil, I think, can't see Raman. Kapil, please carry on.
Dr. Arya, it's a great presentation on use of hook plate, which I must confess I've stopped using it for a number of reasons. But what's your indication to use it? Why would you not use a CC device like a dog bone or something to do a procedure which is more invasive, which needs a second intervention? When would you prefer to use this over a dog bone device? The other thing about the plate thing is I've got an interesting case to discuss, discussion about a plate that was, and I'm not going to go into that, but we'll talk about that later on. But just why would you use this rather than something else, like a dog bone or a CC device?
I mean, I don't think that you can sort of divide the indications into A versus B. I think you can use either of the two, a suspensory devices or a hook plate, for same indications. So I would not say that in this particular case, I would go for the hook plate. In that particular case, I would go for the suspensory devices. If I had to stabilize the ACJ, I would use the hook plate. And the reason is very simple. I've been trained for that from the beginning. I'm very satisfied with it. My results are good. It gives me a very quick operation, very reliable operation, very good fixation. And the only downside is the second operation to remove the hook plate. So I talked to the patient, very clearly before that. And I am quite confident that this would give a good fixation. I would achieve my aim, but the price to pay is the second operation.
Raman?
And what I've observed is that hardly any patient would disagree with that. They say, yeah, fine, go ahead. Whatever procedure you feel is you satisfied, you sort of happy about it, go do it. But that doesn't mean that the suspensive.
That's fair enough, Anand. You've used it for a long time. You've had good results.
Yeah.
You feel no need to change it. I think that's a fairly reasonable logic to follow. I think.
Yeah.
Raman, you had a question for Dr. Arya?
Yeah, I mean, just two questions, Dr. Arya. One, did you have any incidents of AC joint arthritis in your cases after hook plate fixation?
I don't remember specifically, but I haven't particularly looked at that. But what I remember is that none of the patient has come back with any symptoms or anything suggesting that the AC arthritis has been there. My patients, somehow, I don't know why, has been mostly young patients. And most of these patients, I think they are under 40 years of age, quite a lot of cyclists, and the people go to the gym quite a lot. They do exercise quite a lot. So I don't remember actually having had, but I just said that I think in one or two patients, they did not wanted to get the hook plate out. I left it as such, but otherwise most of the patients, I suggested to them to get it out.
Secondly, how do you close the deltotrapezial fascia when you have applied the plate on the clavicle?
No, basically I keep the plate underneath there and cover the fascia over the plate.
Over the plate.
So, yeah, so I just
you stitch the deltoid fascia to the trapezial fascia over the plate.
Over the plate, yeah. So
do you do a pant over vest, or do you just leave it as such?
Sorry, say again?
Do you just do a side to side closure, or you do a pant over vest? Do you double breast it?
No, I just do a side to side closure.
Side to side. Okay.
It's just that there's a bit more padding over the plate then.
Nilesh, quick question. Dr. Patel, can you start sharing your screen while Nilesh is asking a question?
It was the same question regarding AC joint arthrosis, so I think that was already addressed.
That's fair enough. Dr. Patel, if you thought that was a controversial topic, you have the bombshell of all controversies now with you. So here you go, Dr. Patel. You fighting on a very losing wicket. It's like the English team playing in Narendra Modi Stadium, isn't it? You have very little chance. I'm telling you, the attack is very, very strong out there. So let's hear you talk about the Bosworth technique. Dr. Patel, you're muted.
Lower right corner, you got the, come down to lower right.
Sorry, good evening to everyone.
Please. Can you do a presentation mode, please? Can you go on?
Yes. I just starting my slides now. Anik.
Slides should be very big.
Okay. As anatomy is already discussed. So we are operating mainly grade 3 and grade 4 and grade 5 AC joint. Grade 1 and grade 2 we are keep it conservative. We are fixing with a Bosworth screw, and we have excellent short to mid-term result using this technique. Our patient selection criteria is that isolated type 3 to 5 type 6 injury, patient with symptomatic type 2 and failed conservative management, and all untreated asymptomatic symptomatic results. We exclude polytrauma patients and type 1 injury. These are many methods, and we are using Bosworth technique. So in our technique, we operate in a B chair position under general anesthesia, and we put a long longitudinal incision to gain the sufficient access to AC joint and surrounding structure. The incision should be linear in nature and extending between the tip of the coracoid and acromion. So we remove the disc and capsule and cut the clavicle in the oblique fashion. And then the tip of the coracoid, the coracoacromial ligament, and its insertion to under the surface of the acromion is identified. The acromial end of the thoracoacromial ligament is isolated and detached using reciprocating saw. So we take the coracoacromial ligament with the bone chip. A 5 to 10 mm osteotomy cut is made from the under surface of the acromion, and a piece of the bone with the coracoacromial ligament attached is preserved. This pedicle bone plug anchored to the tip of the coracoid, prepared with 2 to 3 number 2 ethymon suture passed through the both bone and tendon by modified Krakow technique. We prepare under surface of the clavicle. 2 or 3 triol feet in the upper end of the upper cortex of the clavicle, and the bone plug is passed from these two. The bone plug ligament complex is held by ethibond, and it's then tested to ensure complete fit within the clavicle. If additional length is required, then we partially release it from the coracoid. The free end of the graft is tied with ethibond suture, and then it is passed through the drill holes made in the superior cortex of the clavicle, and the bone plug is guided to fit within the bed created for it. With the acromial bone plug within the intramedullary canal, sutures are tensioned and the clavicle manipulated to sit in the normal anatomical position. And this repair is secured with the several knots to reinforce the fixation. In the next step, we put a K-wire from the superior part of the clavicle into the coracoid process, following which we take the size and then insert a guide wire after removing the K-wire. And we put a over drilling over it, but we drill only single cortex in the coracoid. After measuring the length, a Boswell screw is inserted with the washer and bicortical hold is purchased. After the soft tissue repair is made, ensuring the closure of the AC joint capsule and the fat overlaying the repair, and the closure is done. So these are the pre-op and post-op X-ray. In post-op protocol, shoulders are protected with arm pouch sling for 4 weeks. Passive range of motion exercise started on the second post-operative day. During first 4 weeks, only pendulum exercises were allowed. After 4 weeks, the patient was allowed to start active mobilization of the shoulder joint up to 90-degree abduction and flexion up until approximately 8 weeks, when the screw should be removed under a short general anesthesia or under local anesthesia. Mobilization is only allowed below shoulder level because above 90-degree of abduction and flexion, the clavicle undergoes rotation in the cortical plane, and hence the screw will certainly loosen, but may also break. Sports and heavyweight bearing are not allowed before 12 weeks post-operative. Actually, we are working in the government setup, so it is a very cost-effective method. It is a simple and reproducible, fast. It will take 30 to 40 minutes to complete the surgery. Minimal complication in our limited experience, only 2 or 3 cases where we have loss of reduction. It replaces the CC ligament, and means of one type of biological fixation we try to achieve. We sacrifice patients all coracoacromial ligament to augment the AC joint, and then structure will hold by Boswell screw. So we use autograft taken from the nearby site only. That save the patients from another incision, especially if take the graft from the hamstrings. We have operated around 20 shoulders that from the BSF by this method, and they have full range of motion and can carry heavy load in the follow-up. Pitfalls are neurovascular complications, coracoid fracture, implant failure, implant back out, implant impingement, restricted range of motion, increased instability at abduction, and increased risk of dislocation in athletes. Basically, we are sacrificing coracoacromial ligament, which is a stabilizer for superior migration of the humeral head. But we have not seen any complication in our patient in last follow-up. I think it is 4 to 5 years follow-up is there. So it requires long-term study of it after is there any effect due to sacrifice of the coracoacromial ligament. So despite complication, and as our result demonstrate, Boswell screw fixation with coracoacromial ligament used as a acromial AC ligament and biological fixation, It is adequate and easy to perform surgical procedure. However, there is still an uncertainty between surgical and non-surgical treatment. Finally, in contrast to newer technique, this one always requires second surgery for final implant removal, and that should be kept in mind when using this technique.
Thank you so much, Dr. Patel. That is absolutely wonderful. I don't think too many of us would have done this. I have assisted in a few. I think Dr. Basim, would it be right to say you've had a go at doing some of these?
I have my one is just simple technical point that what I would understand that you first fix the CA ligament and then tighten the screw. Wouldn't it be better if you tighten the screw and then fix the ligament? That is one thing which I found maybe technical. I'm not talking about the biology of the procedure or the justification or the logistics, just the technical aspect. Probably you should tighten the screw and then fix the CA ligament, like a weaver done.
That makes a lot of sense, Dr. Patel. I mean, why do you do it the reverse? It makes a lot more sense to first stabilize it and then tighten the, because the tension will vary based on where the screw holds that. Any reason why you do the reverse, Dr. Patel?
Just to get the reduction with the fixation with the thoracoabdominal ligament and check the stability.
Okay, so, Dr. Maheshwari, you had a go at some of these?
Yeah, my question to anybody who does CC fixation is that you have a fixed point on the coracoid. Everybody knows in the middle of the coracoid, most likely, whatever method you use. Where is the point on the clavicle? Because if these 2 points are not isometric, if I can use that word, your reduction of the AC joint will not be proper. And you can't go 2.5 from the end of the clavicle in patient who is 4 feet 8 inches and patient who is 6 feet 8 inches. That doesn't fix. So how do you decide the entry point? And I asked this question in the chat to Nilesh as well. If the entry point on the femur is fixed, then in every patient, your pressure of the CC area will dislocate your joint in some way or the other. I often fail to understand this philosophy. Where is the entry point in the clavicle?
Can I just butt in, Dr. Maheshwari? So my reading on this was there's a very good study which looked at this, and what they said was if you measure the whole length of the clavicle, so the trapezoid ligament is 17% of the length from the lateral end, and the conoid is 30% of the length from the lateral end again. But Nilesh, I think you have something better to say.
Yeah, so I'd actually replied to this question on the chat as well, but just for reason of discussion, I just thought I'll bring it up here. So what has been described in the surgical technique is 3.5 centimeters from the lateral end of the clavicle. And I completely agree with what Maheshwari sir says, that every person is different and the length is going to be different. So you can't have an absolute figure. What my understanding about this vertical stability is that and in the acute setting I'm talking about, in the acute setting, once you reduce your clavicular coracoid distance, you are approximating the torn ends of the ligament also. There is an internal splintage, and in addition to that, that would allow some amount of healing of the CC ligaments. That's what my rationale was, that the internal splinting with the healing would serve in the long run. You're not relying on the device by itself in the long run.
So can I ask a related question? So
Yes,
would it not be better that you reduce the AC joint under vision first? That's what your crux is. You want the AC joint to be reduced anatomically, and then around that fix up whatever you want to fix. Because if your fixation method leads to say 80% or a 70% reduction of the AC joint itself, that may give rise to early arthritis. So your fixation has to somehow ensure that your AC joint is reduced, which in your case you showed by image intensifier while tightening. But you fix the point at 3.5, you're not sure where it is going to be at the end of it. You understand what I mean?
You mean to say that in spite of tying it down, there is a subluxation eventually? That's what you mean to say?
Absolutely. Either AP direction or superior inferior or wherever, unless that isometry of that patient is maintained, you cannot. You tighten something, it will go somewhere else when you tighten it.
Nilesh, can I ask you, if you're only fixing the substitute CC is what you're trying to make, will it make a difference? I can understand the rotatory element, the horizontal displacement, in my opinion, what Dr. Maheshwari is saying is not right. It will not make a difference on the restoration of the AC, because vertical displacement will be restored almost irrespective of where you put it. But the other movements of the AC joints are the ones that you need to worry about. Am I right?
So can I butt in there, Guri?
Please, Raman, please.
Okay, now hook plate will restore the AC joint. Would it? Yes or no?
My answer is yes.
Dr. Maheshwari. Dr. Maheshwari.
Yeah, it will, because you're doing it under vision.
Yes, sir. But still there is a 12 to 15% failure rate.
Of what?
Of the vertical displacement, recurrence.
Because that will never heal. Who knows CC is going to heal or not?
Exactly. So the point is, whatever you do, you have to do within the time frame, which is 10 days. If you do it late, you have already missed the boat. Number one. Number two, suspensory devices do not work on recreating the CC ligaments. CC ligaments are oblique ligaments, and suspensory devices are only doing a vertical stabilization, as Guri pointed out, as Nilesh showed. We are not recreating, but now with single dog button, we are digressing to 2 tunnels into the clavicle, and we are trying to go 15 millimeter from the lateral end of the clavicle and 35 millimeter from the lateral end of the clavicle, creating 2 tunnels 20 millimeter apart, trying to recreate the trapezoid and conoid components. And that shows slightly better results because they are fixing it with an interference screw. But your point is valid. We are not recreating the ligaments. We are just vertically stabilizing so that the scar tissue forms between the minimum distance between the clavicle and the coracoid. That's it.
Correct.
Essentially, Nilesh, the only thing you're aiming to get is AC joint capsular healing. You will never get the CC joint. Although you'll see some ossification sometime, but that's not your aim at all, right?
Well, that ossification is a source of pain.
Guri, we'll come to this basic question at the end when this presentation.
No worries. If you
are we looking at only CC or looking at CC plus AC? That's a very critical question. Maybe at the end of all the presentation, that will be a very key question.
Dr. Arya, very quickly, if you can, your question.
Just a very basic question, actually. You know, I don't know whether I'm completely stupid. All these devices which you use to fix the suspensory devices, the hook plate, other things, I mean, we are not thinking that they would stay forever and stabilize the ACJ. Ultimately, what we are aiming for, they are temporary devices, so that ultimately natural healing would happen in the ACJ as well as whatever healing happens between the coracoclavicular ligament.
Very true.
So number one is that for me, it really doesn't matter if it's a vertical, if it's an oblique, whatever it is, because ultimately we are looking for biological healing in long term to maintain the ACJ. That's number one. And number two is that I just could not understand the Bosworth screw thing. I think I'm completely out of date. You're doing it for acute injuries and you're excising the lateral end of clavicle. I mean, you really don't need to, because you have better methods of fixing the ACJ rather than excising the lateral end of clavicle. Because if you excise the lateral end of clavicle in the acute injuries, it would definitely make the ACJ and the whole mechanism abnormal, unstable. So I just can't understand why you would need an excision of lateral end of clavicle in the acute injuries.
Dr. Patel, very quickly an answer, if you, or is that because you've always done it?
You only the chip from the lateral end of the clavicle, and we are making a coracoacromial ligament act as the AC ligament. Coracoacromial, so it act as a biological fixation and stabilizer.
We understand, Dr. Patel, but why excise it? I mean, is that because you want to play raw area to insert the AC ligament?
Yes, we are making a raw area, and we are removing only the chip from the lateral end of the clavicle, not big chunk.
Okay, Dr. Pandey, can I invite you? Dr. Pandey has been a very, very old friend out here, and I think all of us also remember the famous Leicester course that he organizes. He's been with us very, very often, and welcome again. Very nice topic using the synthetic tape, which seems to be catching the flavor of the day, really. Please, Dr. Pandey.
Sorry, can you see my slides now?
Yes.
Yes.
Oh, sorry. Okay. So, hello, everybody. So I'm going to talk about my way of doing it, because everybody has their own way. This is my way. And this is all absorbable suture tapes and suture repair. And this is my experience. I've now done about 8 or 9, 9 of them. And I'll tell you what I have found. So one of the things which we haven't touched is the clavicle rotates almost 40 to 50 degrees along its long axis. And that is a very, very important point to remember. And it also moves 5 to 8 degrees at the ACJ joint and the SCJ joint. So it's a bone which is quite mobile. And all the techniques everybody has described is fixing the clavicle either to the coracoid or to the acromion, and then mobilizing the shoulder with the clavicle rotating and going up and down. So all these fixation methods, especially the ones where you have non-absorbable synthetic material or screws or endo button, they will either cause a fracture or they will come out of their holes. So it's like a giggly saw. And I think that is an important point to remember. Now, these are some of them are from other articles. Some of them I've had this referred. So I just want to show you the complications of all these other techniques which have been described. You can get clavicle fractures, failure, then they have to remove all these synthetic stuff, which is very, very expensive and causes a lot of problem. Never use K-wires, anchors pull out. And I think this is because it's fixed to the coracoid. Another fracture. Here, the dog bone is cut out and it's got a coracoid fracture, which is quite a devastating complication for a straightforward injury. Hook plates can fracture. Again, one of these has pulled out from where it should be. Here you see osteolysis. Bosworth screw pulls out. Never use K-wires. So all of you have seen these kind of problems. And I just want you to concentrate on this slide. As we all know, it's a non-essential surgery. There are people who think that this surgery should not be done. We are doing it for quality of life. So the surgery needs to be simple and not be prolonged. I saw somebody do a arthroscopic ACJ stabilization for 2.5 hours. And there has to be a small learning curve. All the other bits have got huge learning curve. It should be cheap and it should have low complication rate. And the complication should be simple. It should not be so devastating that you can't salvage them. And hopefully if you don't need a second surgery, that will be better. So I use an all-absorbable material. Nothing stays in, it all dissolves in 3 to 4 months time. And the most important thing here is you have to do the surgery within a week. As Raman was saying, you've got to do them early. Make a decision early and repeat, do the surgery early. This is the vicryl tape I use. And these are PDS sutures, double loop. And you can double it, make it 4 strands, 8 strands, depending on the quality of repair you want. This is a 25-year-old cyclist, very elite. Fell, has got a grade 5 dislocation. This is what I have done. So I expose it. You can use 2 small incisions or 1 slightly larger incision. I get the ACJ joint out. And I use this self-made hook, which I made from K-wires, and that I use to pass this tape under the coracoid. No drilling holes in the coracoid. You use this and it comes out. Only thing you have to be careful not to get anything vital from the medial side of the coracoid. So now the tape has been passed under the coracoid, and I take one limb under the clavicle and I tie it. Not yet, I will tell you when. But no drill holes are made in the clavicle. It is going underneath the clavicle and it will be tied on top. This is an absorbable vicryl tape which will disappear in few months' time. So this is the end, but before I tie and put these wires, I put my figure of 8. across the ACJ joint, acromion clavicle, and I also put a box suture to stabilize it anteroposteriorly. So I put all these sutures before I reduce and tie. And once I have passed all these sutures, I reduce the clavicle with the acromion and put a wire, temporary wire, to stabilize it. Then I tie all the knots. So there's a figure of 8 knot and there is a box knot which will hold things together, and then I pull the wire out. But before I pull the wire out, it's most important, which the arthroscopic techniques don't talk about, which Raman did talk about, is this soft tissue repair on top of it. I think this is the most important thing. You repair the trapezius, fascia, deltoid. If you have to double breast it, it has to be a very, very robust repair, soft tissue repair over your bony repair. Otherwise, I think it will fail. And this is one thing very difficult to do arthroscopically. So here was that patient I showed you, grade 5. This is introp, no non-absorbable material, no metal, and that is almost 6 weeks after the surgery. It's still holding. Another one, a lateral nerve clavicle. We couldn't fix it with metal plates because it's very, very lateral. Again, I use the vital tape, put the tape underneath the coracoid, take it on top, and pass your figure of, like this figure of 8 sutures across the acromioclavicle joint and a box suture to prevent anteroposterior. And before you tie everything, reduce it, put a wire, hold it there, then tie everything, and then repair these soft tissues. Very important, robust, double breasting, pants under the vest, whatever you want to do, but it has to be a very good, robust soft tissue repair. And then you take the Kevara. This is the same patient. This is 6 months post-op, and it's still in place. I have also done this, Shashank. This is your grade 4, which you talked about. Again, we have opened it, put my coracoid, the tape under the coracoid, passed figure of 8 sutures, then reduce the clavicle, hold it with a wire, tie everything, repair the soft tissues on top, and remove the wire. Post-op, I keep them in a polysling for 3 weeks at least, only pendular exercise. I go slow, and at 3 weeks they start active, assisted active, and 6 weeks active, but they don't do sports for about 3 months, by which time the tissues are beginning to heal and the suture is going to get dissolved. The total cost of my material is less than £5, less than 500 rupees. Cost of any other implant, endo button you use will be from $500 to $1,500 or pounds, whichever you want to deal with. Very, very cheap, much cheaper than the Bosworth screw. The important thing is early surgery, pass all tapes and sutures before reducing and tying the knot, and you reduce it with a K-wire, remove K-wires. There is no drilling of coracoid or the clavicle. When I'm passing these sutures, I may use a 2mm drill of the lateral aspect, but 1 or 2 only. And the most important thing, in my opinion, is a very good soft tissue repair on the top of the clavicle. The fascia, the deltoid, trapezius needs to be repaired very, very well. Double breast them, and that is what's going to help you in the long run. And that is something which arthroscopy surgeons may find very difficult. And a slow mobilization, gradual mobilization, that is very helpful. Thank you.
Thank you so much, Dr. Pandey. You started reminding me of Dr. Bhasin. He used to keep on coming out with these techniques which are the economical ones, the no metal kind of techniques. And I was one of the very young surgeons out there, very influenced by Dr. Bhasin. And I think you are the next man who's following up on him. Okay.
This is not, I would like to take issue with that. It's not a cheap technique. It's something which does the job. And it happens to be a cheap technique, because I know when you say cheap technique, people think of different things.
I didn't mean
it does the job, and it follows the biomechanics and anatomy. If you fix the clavicle to coracoid or the acromion permanently, because the clavicle is rotating, it will cause damage to either the suture or the bone.
I hear what you say, and I'm okay. Any questions, please?
Gurinder, may I just interrupt?
Please, boss.
I think at the end, as a moderator and as a panelist, we have to summarize one message as to what is the philosophy of this surgery. What are we trying to achieve and why? And what are the different methods? And they're achieving A plus B, only A, only B. So if we know the philosophy of treatment, then we understand which technique should be better in my hand. Of course, economics. So I think at the end of whole presentation, if we can get that clear message, why are we doing this surgery? Is it just to make it good on the X-ray, immediate post-op, and whatever may happen later? Or is there a philosophy behind treating? I think that's the message at the end of it we must give. Thank you.
Okay. I think so. I think when all the operative sessions finish, would you be able to give us that little thing which Dr. Maheshwari has asked? So if you can summarize it at the end, I'll request you at the end. But my next speaker for the day is Joydeep. So Joydeep is from King's College in London, and again, a big interest in shoulder and upper limb surgery. We're not talking, Joydeep, of chronic injury. So we'll be talking about doing some reconstruction procedures later on. Do I take it, Joydeep, you describe chronic as anything after 2 weeks or 6 weeks? What do you call that?
Yeah, I think that, well, that's a good, can you hear me?
Yes, very well.
And you can see the screen?
Very well.
Yeah, so I think that's something I'll mention in my slide, but I think I would go for about 3 weeks, up to 3 weeks is the acute. I mean, I know we talked about 10 days to 12 days to 2 weeks. I think in terms of some of the literature, it shows about 3 weeks is when it stops, the CC and the AC stop healing. But and I think beyond 6 weeks is probably for chronic, but I think probably most patients we see it's going to be about 3 months or so. But I'll come back to that as well. So the debate about why you should or whether you need to operate on these patients. And I'm based at King's, which is one of the 4 MCCs in London. And we've had some great talks talking about the acute side in terms of the incidence and the mechanism of injury, and then also in terms of the anatomy. And obviously the mechanism as such in terms of direct and indirect forces and what we might find on examination. And obviously the key thing is in terms of the classification, most of us use the Tosse and Rockwood variation. And I think that obviously most of us agree that 1 and 2 we treat conservatively on the whole. But if we could identify the 4, 5, then those ones we'd think about in terms of surgical intervention, depending on the patient criteria. But the 3s obviously are the difficult ones where the literature shows that probably there's no difference obviously between conservative and operative intervention. And that's where you need a big discussion with the patient in terms of the needs and indications that they have. And I have to admit, I've never seen a 6 as such, but obviously there are x-rays in Rockwood's book about that. But in terms of those that are not the acute situation, we're talking about chronic AC instability, and I'd probably, most of these patients, you either identified maybe and watch them out to 6 weeks, or else they come to you later on at 3 months out, and they're going to have usually complaining of AC joint pain, but they may have posterior shoulder pain, pain of the coracoid and from the cervical spine, a pain of intra-articular or extra-articular origin. And when I see them, what I'm interested to know is the pain from the ACJ itself, or is it because of pain from elsewhere? So if they've got some pain related to the scapular dyskinesia in terms of malposition, inferior border of the scapula itself or the coracoid, and particularly if there's scapular dyskinesis, then I'm going to want to look at that. So obviously Burkhardt described that, and Gamini showed up to 70% of patients with chronic AC injuries had a degree of scapular dyskinesia. So from that point of view, in my patient selection, I'm wondering if they've got that persistent pain. Have they got, is it related to the ACJ? Do they have horizontal vertical instability as we've discussed? And can they control their scapula, or is it they got dyskinesis, and is that affecting their work or their sport? And particularly what their expectations are in terms of any kind of treatment, because obviously if you don't match those, you're often going to have an unhappy patient, whatever you've done in terms of their operation. And particularly in those patients, I would usually consider at least 3 months of conservative rehab treatment, particularly if they're trying to control the scapular dyskinesia. And often the patient, some number of those patients, the pain may well resolve and improve. However, if you've got those residual patients, which are the ones left over with the the chronic grade 3 ACJ injuries, then therefore you may think in terms of surgical intervention. And we've talked, everyone's talked about all the different types of acute mechanisms, and certainly I've used both the Boswell screws, and Dr. Pandey's talk was excellent. I've used that technique, but unfortunately my vital tape often stretched out and had problems with that. And you can see here again, just that sort of acute treatment for the ACJ, where you reduce it, repair both the AC and the CC ligaments, and use some kind of tape or other mechanism to help control and stabilize and augment your instability. But in terms of the chronic injuries, as we've discussed, there may be considered non-biological fixation between the coracoid and clavicle, such as suture loops or synthetic ligaments, such as a Surgilig or a Lars. You may want to use biological reconstructions, such as an allograft or autograft, such as palmaris longus or semitendinosis, something like that. Or you want to use a ligament or tendon transfer, such as the Weaver done. And certainly, I tend to use the Weaver done because it's relatively straightforward and simple from that point of view. And Weaver and Dunn showed in the American JBS in '72 their technique, which is basically that transfer of the CA ligament. And they didn't use any augmentation as such, and they got good results, mainly acute patients and some chronic ones. This is Copeland's, because the problem with the Weaver done is it only, with the CA ligament, only gives you about 20–25% of the strength and stability you need to count for the CC ligaments. Therefore, most people go for some kind of augmentation technique. In this one with Steve Copeland, he's used PDS tape, and obviously you could use the PDS loop as such, the suture loop as such, from that point of view, which may well help. And you can see here we've got that sort of chronic type 3 dislocation. And nowadays I've tended to go for a more predictable, in my hands, tightrope technique to augment the Weaver done, just to give that extra stability in terms of the CC instability. And in terms of literature, so as we've heard from all the things that good results, whichever technique we've been reported. So Weaver done with the Bosworth screw, which we've heard can give you excellent results. Weaver done using the tightrope can give excellent results. And even the Weaver done comparison to, this is, we're using both the Weaver done comparing to the Surgeries, give comparable results, maybe slightly better than the Surgeries. And as Dr. Agarwal suggested, there was a meta-analysis, and that showed, looking at non-biological fixation, biological reconstruction, or the use of a ligament transfer, such as We've done, there's probably little difference in terms of the outcome measures and the in terms of complications. So what do I do? Well, in the acute, as I said, that get them as early as you can, at least below 3 weeks. In that situation, you want to consider open reduction, repairing the CC and AC ligaments, and augmentation. I tend to use the tightrope now, but I've certainly used both the Vicryl tape and the Boswell screw in the past. And for chronic injuries at that situation, if there's no reason not to, I'd usually use a modified Weaver done with an augmentation tightrope. Thank you.
Thank you so much, Joydeep. Any quick questions? And Kapil, you can get your take this. If you can leave the slide, Dr. Sinha,
and question.
We can have a question. Raman. Yeah, okay. Raman.
Dr. Sinha, I had usually found the technique that Weaver done described originally, that you take a bone plug from the acromion and then you transfer it to the distal clavicle by doing a small excision and creating a trough at the inferior aspect.
Yeah.
What actually we are doing is, I mean, it's a great procedure. And of course, we know the relative lack of strength in the CA ligament as compared to the CC ligament. But the relative length of the CA ligament is much more than the length of the CC ligament.
Yeah.
And when we take the plug of the acromion and then we transfer that plug of acromion to the distal clavicle, we are ensuring the cosmetic deformity on the table.
Yeah. So I don't use the bone thing. I just use, like Steve Copeland taught me, I take it off below that. I don't take a bone plug with me. I take the actual CA ligament. And
so you shorten the CA ligament, you take it with substance.
I'll use it enough to give it to transfer, open up the medullary canal, drill the 2 holes for my tape to take it through that way. But I don't use the bone plug, no.
Okay, if there are no questions, can I invite Dr. Kapil? Dr. Kapil, I think, again, regular on the Indian circuit now. Works as a shoulder and upper limb surgeon in Aberdeen, special interest only in shoulder surgery. He's going to be talking about AC joint reconstruction, but he's going to do a reconstruction using autologous tendon grafts. Kapil, please.
Thanks, Gurinder, and thanks, Prateek, for the invitation. Always a pleasure to interact with everyone. Pity we are doing it over the ether and not in person, because I was envious of Dr. Maheshwari's beer. But anyway, I'll move on. We've had some excellent talks, and we've heard this all about the stability of the AC joint, the role of the corticoclavicular ligaments, the anatomy of the conoid and trapezoid, and of course the role of the AC ligaments. And we've heard that, and just to sort of again repeat it for the sake of reinforcement, that the CC ligaments are important for superior inferior stability, while the AC ligaments and a repair of those contributes to the overall AP stability. I think that's the point that we have to remember for whatever reconstructions we are doing. And my remit is to talk about the chronic injuries and not to talk about the acute injuries. So I'm just going to come to the type 3s. You've heard about the Rockwood classification, and I think there is a general consensus that for type 3s, most of us will try a non-operative in most of the acute injuries, and will do a surgery if there is ongoing symptoms, which essentially means that we are going to commit all of these type 3 injuries to a chronic situation. We're going to be doing a reconstruction. At what stage do you make a decision? As Joydeep said, and Raman said earlier on, Raman said 10 days is acute, and beyond that, you're committing them to a chronic reconstruction. Joydeep alluded to the fact about 6 weeks. So if you're making a decision about 6 weeks, can you still go with just a repair rather than reconstruction? For me, practically, there's very few patients where we are going to make a decision before 6 weeks. So in my practice, if I've got a type 3, unless the patient was very pushy for surgery, the first instance, we are committing them to a soft tissue reconstruction. And, we're going to leave the 4, 5, and 6 for the time being, because we presume that we have operated on most of them acutely. And as we discussed before, the aim of the surgery is to reduce the AC joint in both coronal and sagittal planes. I think that's very important, because that brings to the fact what Dr. Maheshwari alluded to, where do you make your drill hole in the clavicle, etc. And we can probably discuss it later in the panel discussion. And the aim of your surgery is to restore the corticoclavicular ligament, protect it if you're doing an acute repair, that's the whole idea, and afford some other stability by restoring the superior AC joint capsule as well as the deltotrapezial fascia. We have seen pictures and brilliant technique from Nilesh about acute repairs. I'm not going to harp on it, but the key here is that your device is acting as an internal splint, and you're encouraging primary healing of the ligaments. With those things, there have been failures, and people have gone to try and reconstruct both conoid and trapezoid ligaments with sort of Y-shaped constructs, which again have had a high failure rate. So coming to the chronics, again, there is a number of devices on the market. You've got the large ligament, you've got the lockdown device. And I must confess, I've used all of them and burnt my fingers with all these devices in the past. This is a case in point with a tightrope, and there's an anchor there which is trying to repair the ligaments of across the AC joint. Primary surgery not done by me, may I hasten to add here. 3 months later, patient comes here and it's failed already. So what do you do at this stage? We've heard Joydeep saying we were done with your transferring CA ligament. Yes, the huge advantages. You don't have to go elsewhere to get your graft. It is readily available, and you can just shift it across. So I'll just start with this case. This is a man who's about 49, right-hand dominant, very active. There's a lot of cycling, fell off his bike at the height of lockdown, in which I'm sure all of you are aware has been a very protracted one in Britain, and came to see me 3 months after the initial injury with this. Now, you don't need fancy investigations. It looks like a type 5. It is behaving like a type 5, and it's now 3 months old. So what are my options now? Do I just go and fix it with a clavicular device arthroscopically? Probably difficult to reduce. do an open reduction, put a synthetic device only. And we know that there has been some evidence in the literature, especially from Angus Wallace, where he's shown growth of collagen fibers into the device. But I think it acts like an onlay device, and it's got no structural integrity to give you that stability. So you have to introduce some biology here. So this is what I do, and I'll just take you through the technique here. I tend to use a vertical incision, and I can expose the coracoid process, as you can see in these two images. And I take a semitendinosus graft, and I circle the semitendinous graft under the coracoid process. And I try and keep it right at the base of the coracoid. Now, you can imagine that will slide. So before I pass the graft, I debride the undersurface of the coracoid, take a little burr to it, and just freshen the bone up there so that I get some biology where this graft is going to stick. Then I use the dog bone device, but because I'm doing it open, I drill my coracoid and clavicle drill holes separately. So the dog bone device is just anterior to the semi-T graft, which essentially prevents my semi-T graft from sliding forwards. And this is the tapes from the dog bone device. Then I take these two limbs of the semi-T to go along the clavicle. So I will use this medial limb of the semi-T to go behind the clavicle, and thereby I'm trying to pull the clavicle forward as well, reducing the clavicle in an AP direction, and at the same time giving me some AP stability as well. And then I incise the delta trapezial fascia on top of the clavicle and use a curved artery clip to retrieve my semi-T graft. And once I've got my two tapes over the clavicle like this, then please ignore the screw here. This is an animation. Then I will drill a hole here and retrieve my dog bone device and reduce the clavicle down. And then I tie the two tapes, the two limbs of the semi-T on top of the clavicle in such a fashion. So you must reduce the AC joint before you bring the two limbs of the semi-T to suture over each other. So why do I do this? I think I get biology with the semi-T graft. I do get an AP correction, and I'm trying to recreate the two limbs of the CC ligament. It's not anatomical, and I'm sure Dr. Maheshwari will question the isometricity and the restoration of anatomy. It is not anatomical. What I'm trying to do is to get a bigger load transfer between the two and try to reconstruct the ligaments. Once you've reduced this, I check the AP stability of the clavicle. And if I've still got some residual AP instability, I would use an internal brace across at the top of the clavicle. I know Marcus Schiebel uses the same hamstring graft, and he drills a tunnel across the AC joint and uses that to restore the AC joint. I've never done it, but possibly I could do that in the future. But presently, if I've got residual AP instability, I would put an internal brace on top of the AC joint to restore that. So this is that case that I showed you earlier on. That's his intraoperative images. This is another boy who's quite young. It's a grade 3 or grade 4, or it's a grade 3 or 5, probably a grade 3 injury. Came to see me 6 months after the original injury with a lot of shoulder dysfunction. Performed the same autologous reconstruction, and this is his function 6 months after his injury. So good restoration function. I agree it's not as cosmetic as the arthroscopic ones, but I think doing it open in a chronic situation allows me to address the superior delta trapezial fascia. I reduce the clavicle under direct vision. So this is just to recap the steps. It's a longitudinal incision, expose the AC joint and excise the distal clavicle. Coracoid is exposed through the deltopectoral interval. Debride the undersurface of coracoid. Pass your semi-T under the coracoid using Leahy's clip. And then drill through clavicle and coracoid, pass the dog bone through coracoid anterior to the graft. Shuttle the limbs of graft to the deltoid and behind the clavicle, pull the clavicle forward. After you reduce the AC joint, stabilize with dog bone, and then you suture the two limbs of the semi-T over the clavicle, medial to the dog bone button, and repair the fascia. Post-operatively, I keep my patients at sling for about 6 weeks. For the first 3 weeks, they can do external rotation with their arm by their side and just active assisted forward elevation to 45 degrees. In the 3 to 6 week mark, we increase the elevation to about 90 degrees, but don't allow them to go overhead till about 6 weeks, and after which we commence overhead movements and no overhead strengthening till about 3 months from surgery. I've used it for about 5 years now, done about 12 cases. I think they all creep a little bit, but none of them has come back to say that they are not satisfied or their function has deteriorated with time. But I can't give you objective Oxford scores, etc. But overall, been quite happy with the technique so far. Thank you.
Thank you so much. Kapil, 1 or 2 burning questions quickly. Let's save a little bit of time before I ask Prateek to come in.
Just a second. Yeah.
I think Kapil missed out on excising the lateral end of the clavicle, and I think Prateek will tell him.
No, I did not. I did not.
Right.
I can go. My slide had it excised distal end of clavicle.
I missed it. I thought Prateek would need to tell you how to do it. But the next talk is Prateek. If there is no other questions, I think Kapil adding that graft and extending that semi-T. I think you use a semi-T, right? Or semi-T can be extended to that capsule over the AC joint. That seems to make a lot of sense to me. We've tried it once, and there's enough graft. Normally, you're always cutting off graft. So using that graft to extend as something is a very useful idea. Prateek, can you start, please? So Prateek is, sorry, I'm not going to introduce Prateek. I mean, that would be, so I think everybody knows Prateek. He's a big man out there. I mean, very well known in Delhi for his work in sports medicine. Works in Ganga, and I'm going to leave him to do the rest.
Just as you said, I have got stuck with some here because I have managed to get my. Can you see my slideshow?
Not yet, Prateek.
Okay. So there is some. If you want to,
I can start some questions.
I will just get this thing sorted.
Okay, I'm also going to invite Raman, my co-host for the next discussion session. Raman, you tune in, right? If you can put your video on as well.
Yeah.
Raman, first I think we'll take some questions which have come from the audience. So one delegate has asked, tension band wiring, any reason not to use it? I think the question's been answered mainly because of the migration of the wires, the high failure rate. Most people have given up on that. Too many problems. I mean, the wires poking out of the skin, getting infected. There's just too many issues.
Not only the skin, the wires have entered the heart. The wires have entered the spinal cords.
Quite right. So it's something not to do.
In my case, the wire was lying medial to the scapula. I took it out from making an incision on the medial border of the scapula.
And that's a disaster. Okay, so Raman, can I request you, please, if you can actually talk about positioning of the C-arm for actually intra-op visualization, how do you make out whether you've actually got it at the right level or you too high or low? If you can tell us about
first thing I would want to tell that the literature says there is no evidence that intra-op imaging control improves your reduction. So once you are doing open or once you're doing, you have to push it down according to the AC joint. That's one. But if you want to use it, so you have to use it orthogonal to the AC joint. So I bring the C-arm from over the top. Nilesh has shown from the side. I tend to bring it over the top, and then I incline the image intensifier on the front side, and the intensifier is on the back side. The camera is on the front side, and we just go at right angles to the AC joint. Basically, the idea is to see the coracoclavicular distance, right, and the AC joint. So if you are looking if you're looking from below, then you can see better. So that you can bring the camera down, and then you can have a Zankart view kind of situation in the OT. So you can tilt it carefully. So I bring it from the top.
Okay. Dr. Maheshwari, any tips on using the C-arm? Anything you would recommend?
Yeah, I think you can use either way. You can use across the table. In a AC joint, I use across the table because it's out of my way, and I'm just looking at a kind of AP view because the patient is in beach chair. So I tilt the image intensifier accordingly. I don't think it's a big deal. As an orthopedic surgeon, we are always used to using an image intensifier, whatever literature may say. You know, and you can't see things properly, and it is just a good buddy for you to give you that security that everything is all right.
Okay. One more question from the delegates. I think Dr. Pandey, if you could, sorry, Anand, if you can take this. How do you check the correct size of the hook plate to use? Do you always use a smaller one? Is that what you said? Anand?
This is a little bit of a guesswork. So basically, in these shorter people, you start with the smaller hook. And there was only two sizes available, two options were there, 15 millimeter, 18 millimeter. And if you feel that hook is too tight, because if the hook is too tight, then the medial end of the plate would be lifted up too much up from the clavicle. So in that case, just use the wider hook. So I agree, there is no hard and fast, no clear-cut way how to judge is there. You just have to try both different sizes on the table.
Okay. Can somebody please log in Nilesh? He got disconnected. If somebody, I think Prateek, I might need your help to log in Nilesh, Kamat. Prateek, can me and Raman carry on with the discussion?
Yeah, please. I'm just trying to, if Raman wants to go ahead with the panel discussion, I would join because there was 3 presentations, different kinds. So they've got, for some reason, into each other.
No worries.
So,
no worries.
Can you see my screen now?
We can.
Huh?
Yes, we can.
So we are in business now. So everybody can see my screen?
Yes.
Yes. Great. Sorry. So can I proceed?
Please.
Great. Thank you so much, Gurinder. We've already seen that how well we fix, and then if we have a status of acromioclavicular pain. So this is the last talk because that is the commonest thing that we see is acromioclavicular pain, and it forms a big part of our shoulder pain thing that we see in a clinic. And the precipitating cause is generally OA, which may be acutely precipitated, but because of acute injury like fall and outstretched hand, or injury directly to the ACJ, or it could be because of repetitive strain, which we see very often in overhead athletes like weightlifters, boxers, and basketball players, and they present with pain, and they have this kind of a picture. Here they have a repetitive stress over the lateral end of clavicle, which induces the vascular response, and that leads to osteolysis, and this leads to microfractures in that area, leading to subchondral changes and chondral changes, and ultimately presenting with OA and painful shoulder. The other causes of painful ACJ could be age-related arthritis that we see, and sometimes occult or frank instability, along with inflammatory pathology, which are other causes of ACJ pain. So if I look at my last 1 year's practice, what scenarios do we see? Commonest is this one, 61-year-old male, right hand dominant, pain for shoulder for over a year, has had 2 trials of conservative treatment and steroidal injection without any improvement. He's a cardiologist and wants to go back to practice. This is his MRI. So what do we do next? Similarly, another scenario, 39-year-old, he's a dentist who does a lot of work with the weightlifting and body gym work, presented with pain in right shoulder and tenderness local area. And you see the Zenka views show OA changes. Again, 2 full course of non-operative treatment failed. And he comes back, his MRI show us the changes as we see, and he's wanting to go back to his workout and wants something done about it. Third is this computer techie, again, 32-year-old male presenting with pain in the right shoulder for last 1 year, and all the tests were positive, and the X-ray shows the lysis at the lateral end of clavicle. MRI also shows, I'll show you in a minute, And he again had a trial of non-operative management and did not succeed. He had good relief, but the moment he would go back to lifting up weight, within 6 weeks have symptoms. So all these three are failure of non-operative treatment. Clinical presentation, exam, imaging has already been covered. So the management here, as we have seen already in this previous experience, that steroidal anti-inflammatory only offer a very short duration relief, and they also do not alter the natural disease process. So most of them fail sooner or later. In the study, 67% failure within 4 months who had to be converted to excision of distal end of clavicle. So surgical treatment is warranted, and more than 6 months of non-operative treatment has been undertaken. And when we plan that, we need to give due consideration to the occupation of the patient, age, degree of activity limitation, shoulder dominance, and patient's goals as to what they want to do. And if they all fit in, then yes, distal clavicular excision or resection to prevent abutment can be taken. And if when we decide, then this question, what was being raised earlier as to how much we remove, and we have seen the older literature said 15 to 20 mm, especially when we were doing open, and then that would lead to a lot of instability, because this article from Steen, which Ashish had also earlier alluded to, shows that the AC ligament, which is important for the stability, attaches on the acromial side at 3 millimeter and on the clavicular side at 3.9 millimeter. So we have 3.9 millimeter on this side and about 3 millimeters. So the ideal resection would be between 5 to 6 mm, out of which 3 or 4 comes from the clavicular side, while 2 or 3 mm from the acromion side, giving us a clearance of 5 to 6 mm, which will be a safe thing to do. So once we plan surgical technique, it could be done either open or arthroscopic. Open is done traditionally, we all know, by Saber's incision. This has already been talked about and has been giving us good results. But arthroscopically gradually has taken over from open, because it provides better cosmesis, accelerated recovery, preservance of AC ligament, so less chance of instability. And there's no violation of deltotrapezial fascia that we have been talking about, and Dr. Pandey and Raman, that how we need to preserve it or re-repair it once we violate it. So when we go to the arthroscopic, one of the technique is superior, which is superior approach or direct, where we use a smaller instruments and do only ACJ pathology. The advantage is there is very minimal soft tissue violation, but disadvantage is we are not able to address the other subacromial pathology. So the overall technique of choice has become indirect, which is the bursal side. So we approach the AC joint from the bursal side, which lets us address the subacromial pathology, which is in fact many times associated with this problem. And there is minimal risk of superior ACJ violation, because that's on the other end or the top end, which is not touched. So when we decide this is the position, it could be either lateral or beach chair. Excuse me for putting this post-op first, because that gives us the ports to describe. So we use the standard posterior viewing portal and standard lateral instrument portal to view and then work on the subacromial space so that we can reach to the AC joint. And once we reach the AC joint, from the anterior side, we have not made the portal yet. We put a spinal needle, which comes absolutely parallel. As Raman was saying, they have different inclination. There are 3 types of AC joint inclination. So which one will be best angle? So that is decided. And then we make our anterior portal here for instrumentation. And very often while seeing from the lateral portal, we were not able to visualize the whole ACJ so well. So we shifted to accessory anterior portal here, which actually gives us a better view from front to back that you will see in the video coming next. And with this, we go ahead. Now, this is the video of the same gentleman that I showed, 61-year-old gentleman with right-sided ACJ pain. And so we start from the intra-articular side. So we are seeing the undersurface of supraspinatus and cuff showing degenerative changes all over. And we cleared it up to see whether this was in fact a complete tear or not. But when we looked at with the probe, it was partial tear, articular surface side. We went down to the bursal side also and looked at bursal side, and that also was maintained. So it was an incomplete tear. we started working on the subacromial bursa, and the spur was identified here, as you can see here, and then we moved towards the AC joint. Now, when we reach the, when we reach the AC joint, we put 2 needles here, as you will see here, the 2 needles coming, and in these 2 needles, we mark the anterior posterior aspect of the AC joint, and then our instrument comes, the spinal needle came from the front, that gave us the direction to reach the AC joint, and then we put these instruments, the RF probe from the front, and here you can see the lateral end of clavicle moving up and down, and a spur at the lower end of clavicle. And once we have seen the ACJ properly, we go ahead and then excise this spur. You can see the changes in the ACJ here and here, and we are going to use the acromonizer bar to take off the spur here, and then in a cutting block fashion remove the clavicle from there. Now, once you remove the clavicle, the most common mistake is not to remove the posterior aspect, and that's what causes pain afterwards. So you need to ensure that you have removed all the bone up to the back, and here we can see, so we had to use a small burr to start our headway, and then we excised the whole of the posterior aspect of the clavicle from front to back, and also not only that, but a little bit of acromion also. Now, once we do that, we will see that the whole of the posterior aspect is clearly visible, and our probe moves medial to lateral, 5 millimeter gap we can see. We smoothen it with the help of a rasp on both the side, and we only leave this place once we see that 5 to 7 millimeter corridor from front to back. As you can see here, nice corridor, and we can see the posterior capsule intact, the superior capsule intact, and then we come back to the acromial, subacromial space and address the subacromial pathology there by removing that spur. If there is a rotator cuff tear that needs to be addressed, that can be addressed. Otherwise, we just co-plane that impinging spur and leave a flat acromion. And what we hope to achieve is this kind, where you see the 5 millimeter from front to back. We don't want to remove more in a way we may cause instability. If you look at the results, open have been giving traditional good results, 76%, but the arthroscopic gradually takes over. If you look at the VAS score at the end of 1 year, the arthroscopic started at a lower, higher VAS score and ended up at lower as compared to open. And in arthroscopic also, direct and indirect has been compared. Clinically, there is no difference between the two, but for a very specific case where there is only isolated ACJ involvement and high-end athlete, we may want to use direct instead of indirect, because theoretically it has a higher, quicker return to sports within 21 days as compared to 42 days. But clinically, there is no difference the two. So in my concluding slide, I would like to say excision of lateral end of clavicle is a viable option for ACJ OA after the failure of the conservative treatment. The safe limit will be 4 millimeter from the clavicle side and the 2 on the acromial side. We need to give due consideration of patient requirement. Open approach has given us good result, but arthroscopic is giving even better outcome. And indirect approach, which is able to address subacromial pathology, is chosen by most. But in isolated case where we want for a higher end athlete a better and quick recovery with only isolated ACJ problem, indirect may have its role. Wish to thank you.
Thank you so much, Prateek. Any questions on this? While we, Raman, please.
Prateek, would you stop at 3.9 millimeter if you don't find the normal bone?
If you don't find the normal bone,
see, distal clavicular osteolysis is a disease.
Yeah.
And once you are going into the clavicle, you find the abnormal bone, you find the normal bone. You immediately know this is a brownish diseased bone, and this is a reddish subchondral bleeding bone.
Yeah.
And the texture, bony texture also dictates you. I had a patient recently when I put my radiofrequency probe on the distal clavicle. without even activating the probe went into the clavicle, not the shaver, not the burr, the probe. Then I had to exercise the whatever till I found the normal bone. So that's what I'm asking. Would you stop at 3.9 millimeters?
See, I would not, because obviously we need to address the problem completely. But if I am excising more than 6 millimeter, because if you look at the Steen article, it started at 3.9 and went to 6.6. So if I am moving more than 7 mm, then I would start thinking that I may here encounter instability.
Yeah,
I start thinking about that even at that stage.
So a lot of difference between 3.9 and 7. That's almost getting to double limit. So 3.9 is, I think, overrated. I have never had 3.9. I have always excised 5 to 6 millimeter and 1 to 2 millimeter on the acromial side. I've always gone beyond 3.9 millimeter, all my distal clavicular excisions, and I've never ever had a problem.
You're absolutely right.
Isolated ACJ pathologies, isolated,
yeah,
and demanding athlete, I would definitely go open. I will not do arthroscopy because when I've resected the distal clavicle, then I can make drill holes into the superior cortex and stitch my deltotrapezial fascia to that to give a secure. One of the patients I operated in 2011 has made the national record now last year, 240 kilos. Open surgery.
Can I ask this related question, Prateek, and similar question to what Dr. Agarwal is saying?
Yes.
Some of these young athletes, the cause of AC joint arthritis is actually a subtle instability. They may have had a minor injury, grade 1, grade 2, and it was basically an unstable joint which led to AC joint arthritis. Would just removing the clavicle or doing a excision arthroplasty of the AC joint will take care of their pain? Or would you like to stabilize it as well? Either CC or, as Raman said, even AC by open method or whatever. Because if the cause is not sorted out, probably this patient is going to remain painful forever.
I agree with you. Yeah, I agree with you fully. If there is instability, which is the cause, then we have to address the instability as well.
How do you decide that there is instability?
So, but then that your clinical finding pre-op would tell you that there is subtle or a frank. If there's a frank instability, then you obviously But if it is subtle instability, then you may not be able to pick it up. I don't have
chronic in an athletic patient who has had that kind of injury. Would it be worthwhile doing both? Not taking chance?
Can I ask you something?
Yeah.
Are you talking about distal clavicular osteolysis or are you talking about AC arthritis?
AC arthritis. Since Kapil is here, so we share a common patient, and Kapil will come into this. He's a polo player who had a severe, young guy, almost young means 60 years, and he had a severe osteoarthritis of the shoulder. And when I looked at him, I said, you have an OA shoulder, frank OA shoulder pain, and everybody thought it needs a shoulder replacement. Till I put my hand on the AC joint and I said, this is the problem, your AC joint is tender. And we almost pushed Kapil into doing a stabilization of the AC joint and excising, and that guy is fine now. Kapil, would you like to share that case?
Thanks, Dr. Maheshwari. I think you're absolutely right. This is interesting. So, as you say, polo player has had a few injuries to his shoulder, fallen off his horse. And the problem is that when we saw him, his pain was localized over the AC joint. But if he went on X-rays alone, he had glenohumeral arthritis. After a lot of discussions, trial of injections, etc., I have stabilized his AC joint using the technique I showed you with his semi-T graft. And it must be, I think I did it with Gurinder, so probably Gurinder will remember, it must be about 5 or 6 years now.
It's been that much, yes.
He's doing absolutely well. He has not had any recurrence of his shoulder symptoms. So, and in fact, one of the cases I'm going to show you in the case discussion will allude to the same fact about subtle AC instability. And as Prateek said earlier on, does it lead to a dyskinetic scapula because you have lost one of the scapular stabilizing mechanisms to lead to, now whatever you call it, dyskinetic scapula or sick scapula or whatever, but I think it is quite a big contributor there. Going back to Dr. Pandey's mechanics of how the clavicle is, that strut which is rotating, and if you've lost one of the connections unstable, things are going to get affected.
Raman, you want to say something?
Yeah, I mean.
Ek minute, Raman. Prateek, I think Dr. Manoja and Dr. Kamat are waiting for you to allow them into the.
Okay, I'll just get the.
Sorry, Raman, please carry.
Gurinder, sorry, Joydeep has had his hand up for a while as well.
Oh, I'm so sorry. My apologies.
Please go ahead.
My apologies.
No, just Prateek, no, excellent talk. And it's a great operation, works very well. Sometimes one of the problems is when you've done it, they get ACJ synovitis, they get synovitis in that space, which is a real pain for them to have. How do you deal with that as such?
Prateek, muted synovitis of AC joint post section. How do you manage?
When you excise it, you get a beautiful result, but often as a complication, when they start rehabbing, do you get them rehabbing straight away, or do you take any guarding? Because one of the things they can get is that inflammation in that space before the scar tissue builds up.
Yeah, we just keep them in a sling for a couple of weeks. They start moving below the shoulder level at that stage. After 3 weeks, we start mobilizing, getting to the 90 degrees. And by 6 weeks, they are doing all the activities. I've never come across synovitis as such. I've come across painful persistence of pain. And initially, I thought that I have under-resected the gentleman clavicle. Went back to look at my records, and it was very clearly that it is well resected. Then I was looking through the literature and found there's an article which said it's actually the traction of the posterior capsule which develops after you've resected the clavicle that is the cause of pain, rather than insufficient resection and abutment. So, but that thankfully that patient settled in a few months' time. So possibly that was the reason. But I've not come across synovitis.
Joydeep, do I take it you've seen some of these problems and you have have you tried doing something about it?
You need to unmute yourself.
Unmute, please.
Apologies. No, I mean I absolutely. What I used to get them. I do what Prateek does now. I used to get them going quite quickly, but what I avoid now is high arm abduction and cross adduction. So you just don't get that contact of the clavicle and the acromion. It's an operation that's fantastic, but they hate you if they get that pain afterwards.
Sure. Kapil.
So, yeah, interesting, Joydeep, and listening to you and Prateek, that you are very cautious with your rehab with the AC joint excision. Personally, I take about 4 or 5 millimeters from each side of the joint, and I've never restricted the rehab. And like everything else, you do get some little grumbles. I see them first at 6 weeks.
Yeah.
And most of them do settle by about 6 weeks or 3 months, but where there is a bit of grumbling, I've always wondered whether you have left a little bit of bone. But in those cases, I have tried an ultrasound guided steroid injection at between 6 weeks to 3 months, which does settle them. So that might be the synovitis you're alluding to. But just sort of, I don't know if we can do a little straw poll, but I have never restricted the rehab in any way after doing an AC joint excision. I just let them going freely and start strengthening by about 6 weeks or so.
Raman, tell me, when you get osteolysis and weightlifters and all, if you stop their weightlifting activity, have you ever seen a reversal of osteolysis? Or is that gone?
Well, it does say that it is a self-limiting disease, but my practical experience is the osteolytic spots do stay, they don't go, even after osteophos and making them addressed. The symptoms disappear, but if they restart, it always comes back. So the guys who get it will get it again when they start lifting. And that's the time when I go in. And I don't go in unless I see the changes radiologically. That means X-ray wise. If I don't see the changes X-ray wise, then, but the latest case was a revelation because X-ray showed no changes and X-ray and MRI showed some other changes, which I didn't find. And then I eventually went to the AC joint and I found that my RF device was going into the clavicle. That is a different issue anyway. So, Kapil, can I ask you one question?
Yep.
Would you do that polo case again? Now, you did that 6 years ago. Would you do the AC stabilization in the presence of glenohumeral arthritis even today?
Raman, it is very interesting you asked me that question. First thing is one swallow doesn't make summer. that's a case in point which tells you that one has to be aware of other pathologies.
Yes, point taken, yes.
And as I said to you, it was interesting that his pain would tie in clinically with an AC joint problem where he had overhead pain on beyond 90 degrees. His rotation was limited by his side, and I did wonder about that whether we should be doing or not. And it was not an easy decision to take. So the answer to your question is whether I'll do it again. I will definitely think about it. I will go and reconsider all my options before I do whichever, whether it's an AC joint or a shoulder replacement. I'll do both. It is possible that if I'd done a shoulder replacement on him, I would have been disappointed, and so would he. But he, being what activity he was doing, and he still wanted to play polo, I did not want to put a shoulder replacement in him. So I hope it answers your question.
Yeah, no, it doesn't, Kapil, because it further builds up. And there was a context to this question when I asked. Most of my patients, when I examine them for primary osteoarthritis or for my, I'm not talking about cuff disease. I'm not talking about the ACJ involvement in the cuff disease. I'm particularly talking about glenohumeral arthritis and even frozen shoulders. So what I have found out that all my frozen shoulder patients during clinical examination report ACJ tenderness. Almost all of them report ACJ tenderness. All my arthritis patients also report ACJ tenderness in the clinic. I have never dealt with the ACJ, and I have only gone for the primary pathology, and I haven't had regrets so far. And especially during the rotator cuff tear arthropathy, most of the AC joints are tender, and we never deal with them. That's why I'm asking this question. So, rotator cuff disease, AC joint involved. When I'm doing arthroscopically, I will excise the AC joint when I'm preparing the cuff. But when I'm doing the reverse shoulder replacement, I am not dealing with the AC joint. Are you dealing with the AC joint when you do your reverse?
It's very interesting. When I was working with Steve Copeland, and probably Joydeep will remember working with Steve as well, that when he did his resurfacing, we always did it through the anterosuperior approach. Excising the AC joint was the first thing that you did in that operation. Since I've been in independent practice and I don't do my replacements through an anterosuperior approach, I don't excise. And in fact, the other day, I was going to review all our unit shoulder replacements. We have not had a single patient come back where we've had to go back and do an AC joint excision.
Exactly.
So there are 2 points to it. One is, do these patients regain the full elevation and abduction, just stressing their AC joint? Again, there is another discussion going on the shoulder think tank forum where I'm asking people about range of motion, but that's a different thing. We've got patients who've got full range of motion where AC joints are still not. So it'll be a good study to go back and look at retrospectively how many of them had actually significant degenerative changes on the AC joint. So the answer to your question is, I don't address that. I don't excise their AC joint when I'm doing a reverse or an anatomical shoulder replacement. Even with cuff disease, my incidence of doing an AC joint excision is significantly less now. I will coplane it and take the osteophyte. I don't go and look for it doing an AC joint excision. I just coplane it and leave it.
Yeah, coplane it. Decompressing it.
So I don't know.
It looks like the patellofemoral joint in knee arthritis. Irrespective of what the X-ray shows, you can actually leave it, and patients seem to get better from that.
If we need to summarize a few points out of this session, one thing that has to come up very clearly is, what does it mean by acute? Which means very clearly you tell a patient, you either get operated, say 10 days, as Raman says, or 2 weeks. Now, what is that cutoff point? Because that is very important for a patient to make up his mind. Now, what is the consensus? Is it 10 days? Is it 2 weeks? Is it 3 weeks?
2 weeks. It is 2 weeks, Dr. Maheshwari.
I think Dr. Maheshwari, most of us would agree that it's a two week is the cutoff stage. Beyond 2 weeks, the healing can be very tenuous.
2 weeks is chronic. Less than 2 weeks is acute.
Okay. Second question is, does one address only CC joint as by technique by Nilesh, which is very neat arthroscopic technique, or is it very important to also address the AC joint where one will have to do some kind of open technique? That's another question.
I cited 2 papers, Dr. Maheshwari. One was the French study, multi-center trial, 2015, which said CC joint stabilization alone is not enough. Marcus Schibel showed 44% failure rate because of the only CC stabilization. 2011, French study 2015.
Would most of the presenter agree to have a consensus that you should address both and not just CC joint?
Yes.
That's the message you have to give, which automatically means arthroscopic is out.
Yes.
Yeah.
I think one of the big problems which we forget is, I don't know, am I going on and on about it, is the soft tissue repair you do on top of your...
Dr. Pandey, I am a fan, totally. I've already switched. You don't need to convince me. Convince Dr. Maheshwari.
No, I agree with you.
This soft tissue repair which you do on top of this is absolutely crucial. I'm using all absorbable, everything absorbable, and that all disappears in 3-4 months' time.
I will make amends to that. I will stop using fiber tapes.
No, the problem is if you use anything which is non-absorbable or metal and you connect the clavicle with any other bone, coracoid or ACJ, it is going to cause problem because the clavicle moves like this. It's a giggly saw which will slowly go away. Either the dog bone or endo button has failed, it will fail, and then the clavicle is saved, or it will break something. And I just want to, like Maheshwari, you said Dr. Maheshwari, you said very important. For me, this is, if you leave it, even in an elite athlete, the disability is minimal. So your cure cannot be worse than your disease. So you cannot put something in there which can cause 20% complication.
Correct. Yeah.
And if you end up with a coracoid fracture, clavicle fracture, what have you achieved? Okay.
So Dr. Pandey, Kapil's technique of looping things around rather than drilling is making more sense with your logic, isn't it? He's not put anything.
Yeah, he's talking of old chronic problems.
Okay.
I'm talking of acute.
So I think
when there is a chronic problem, I understand they have a pain, and then you can do all sorts of things. I'm talking of acute. You have to do something where if it fails, you can leave it. Nothing, no harm done. It has been, you tried and it waits. Now, if you do something and if it fails, you have to go back in to rectify it. That's where my problem lies.
Raman?
Yeah.
Can we have a consensus on distal and clavicle resection as well? Nilesh, acute cases, any chance of a distal and clavicle resection at all?
In my hands, never. In my hands, never.
Let's
Is it
have
okay? Is it okay if I just make a passing comment on the previous discussion?
Sure.
So the only thing is, I think literature is, if you look at literature, it's not comparable. There's a lot of variability in literature, right from time period as to what is acute, what is chronic, where are you drilling your tunnels, where are you not drilling your tunnels, and that's the reason why we can't equate all the results. I'm not saying that arthroscopic is the way forward. We still don't have the answer. That is what I'm saying. I'm very inspired by Dr. Pandey's technique, and that's something I'll definitely look forward to. There's absolutely no denial to it, because in the Indian setting, to have something cheap, which is reproducible and can stand the test of time, is fantastic. What my understanding is that within 2 weeks, if you're doing it, even for the horizontal stability, because you're bringing about a reduction, tissues tend to heal. So that is what the rationale is. The internal splinting is just going to hold on as a splint. That is not something you're going to rely on forever. That was the comment.
Mainly for the type 3B, Nilesh.
Yes.
Once we are talking of type 5, it's a different ball game altogether.
Yes, I agree.
Dr. Vaseem, one question from the delegates is, in the Indian setting, if you want to use a cheap, reliable method of doing an AC joint, tell us one method in your hands which you think works.
Okay, so I believe that if it is a chronic injury, you need to
acute.
Biological material. So biological supplementation using, if it is a chronic one, then biological supplementation with a graft across the CC ligament, as well as the same graft across the AC, the horizontal component, which decides the anteroposterior shift. So I would use the same graft in a vertical orientation as well as the horizontal orientation.
An acute setting?
At just let me complete the chronic part. I am not completely done with that. So, and I believe that all biological grafts, they need to be protected for a much longer time. I would say at least 12 weeks of protection for any biological material to become viable in the human body. So the graft will stretch out very easily unless you protect it for a longer time. I think this is a biological requirement, nothing technical or mechanical. And I would at the same time put a temporary stabilization across the AC joint by threaded K-wires. It will be a temporary procedure just to maintain the reduction, definitely reduce it once the biological material is picking up strength. All biological material picks strength once it is vascularized and subjected to stress. All non-biological material, which is purely metal or purely fiber tape, does wear out, stresses out, and becomes worn out. So that is why biological material is strong. One needs to support by protected mobilization and bridging the AC joint with a temporary threaded K-wire. So this will address the horizontal and the vertical component. This I spoke about the chronic reconstruction. In the acute stage, I will follow the same principle what Dr. Pandey has said. We put in a temporary K-wire across the AC joint. I would say that I would retain the wire for at least about 4 to 6 weeks and then remove it before it has a chance of getting loose. I would go the same whole length, except that the wire can be removed at about 6 weeks time, which is not a major issue. So there you have an elastic material, letting the acute ligaments heal with the help of the vicryl and the sutures, as well as supporting it. Because let me put it, what are we supporting? The material has to support the entire weight of the upper limb. It is the upper limb which has gone down, not that the clavicle has gone up. So a material which is strong enough, either in its own or it gains strength with biological incorporation, should be able to take the entire weight of the upper limb. So that is what I would do.
Gurinder, I think it is time to proceed to the next session.
I agree.
We're already quite late.
Prateek, I'm so sorry.
Maybe we should go straight to case presentation. Will that be fine?
Yes.
Because it's already 7:15.
Yeah.
And
we have a lot of discussion.
So let's have a case discussion, which is always a very interesting session.
Sure.
And we will try to keep it to time because this can get very heated sometime, which is okay. Prateek, would you like to take over and
so you start? You are the moderator. You start the first case, sir.
Okay, Dr. Pandey, are you ready?
With the case?
Yes.
Yes, I am ready.
And after that, Dr. Anand, Arya, then Kapil, and then Dr. Manocha.
Okay.
So let's have your case, please. So we are sitting in the Sports Medicine Center of Dr. Prateek with all the luxuries, as you would see right in the beginning.
Yeah, you guys are chomping away laddus in front of us.
So that's why I'm switching off my camera in between.
Switching off the camera in between, what he is holding, I will not show.
Okay, so this is a case I have of a 35-year-old man who's a very fit and active, does all sorts of triathlons and things like that. He fell off his cycle and he came with this injury a week or so later. And there was a nice lump laterally. So it's a lateral of clavicle fracture.
Maybe go to the slide mode because I can see all your slide otherwise. The suspense is gone. Please go on the presentation mode.
You need to, yeah, that's right.
Oh, sorry. So this is the fracture. And so clearly, because a very fit and active guy, we talked to him. I said, well, it may heal. You may be left with slight lump on the side. And there is a 85% chance that it will heal with a slight malunion.
If I can go quickly, and may I ask Nilesh and Dr. Arya and Dr. Joydeep, Will you fix it? Will you leave it?
I would offer fixation.
Leave it. Nilesh?
I would offer fixation for him.
Dr. Arya?
I would wait for it and see if the position is maintained. And if the position goes, then these fractures can be fixed till quite late without any problem. But if the position is maintained for next 3, 4, 5 weeks, then I'll stay it non-operatively.
This bump wouldn't bother you and wouldn't bother your patients?
Well, I would do a sort of a kind of inform the patient about it.
Right.
And a lot of patients would be quite happy with a small bump.
Okay.
Because if they had a surgery, they would have a scar. So
right.
Some people say that I don't mind a small bump there.
Okay. How about Joydeep? Not Sinha?
Joydeep, you're mute.
Sorry, apologies. Yeah, no, I'd be concerned in a relatively young active man. I'd worry about, if I don't fix it, about problems with non-union. So I'd be tempted to think about fixing it. Obviously discussion with the patient, but I would aim for fixation.
Right. Anybody else wants to preserve it? I presume most people will fix it, or are there more people who would like to be conservative? Anybody out of the panel?
Fix it.
Kapil, Raman, Raju, all fixers?
I think what Dr. Pandey has told us about the patient who's very fit and active and would like to restore his function very quickly, I'd be inclined to fix it. But it involves a discussion with the patient. You can't just access the patient.
We got it. That's okay. That's a fair approach. Okay, Dr. Pandey, all yours.
Yeah, so everybody is right here. I mean, this can be treated non-operatively, but this guy is quite an athlete, and I gave him the figures that there is a 80% chance of healing. There is a 15% chance of not healing. And he said, well, I don't want to sort of wait 2-3 months and then go back to have another surgery. He wants to get back quickly. So rightly or wrongly, and that can be controversial, we fixed it with this plate. And this is almost 2 months, around 2 months post-surgery. And he's by now mobilizing, he's doing reasonably well. Everything is going right.
So I presume the case is here because everything didn't go well. So can I ask comments from Kapil and then Raman on this X-ray? This patient asks you, is everything fine? Kapil?
The few things which concern me here. There are screws in the fracture site. The reduction is not accurate. May I just, and I see that you have used a corococlavicular device as well to reduce through the plate. Is that right, Dr. Pandey?
Yes.
Yeah. I think there is too many screws in the distal fragment and there are screws in the fracture site. So I am a little bit concerned.
You're concerned about the healing of the bone? I'm
concerned about a big gap in the fracture site. Yeah.
That's
okay. So will you not be optimistic that these fractures anyway will heal wherever you left them with whatever gap?
And
okay, maybe Dr. Pandey proceed.
Okay, so this guy is doing well. At about 4 months, he comes back and he says, you know, sir, my lump is coming back and my clavicle is slightly clicky and it's giving me dull ache and my deformity is back. So what is happening? So I did an X-ray.
Okay.
And now he's got an ACJ joint dislocation, which is almost grade 3.
Mm-hmm.
So, and the fracture is beginning to heal. I mean, this one it says, but here there is beginning to heal, and we have got another X-ray. The fracture is almost healing, but this is bothering it. This has got slightly worse. So now he's got a proper grade 3 ACJ dislocation with no injury at about 5-6 months down the road, and he is not happy with the lump he has got.
Yeah, that's interesting. I mean, 2 injuries very, very close to each other, And as I was kind of being optimistic that the fracture will heal, it did heal up. So that was the worry actually looking at the first
they take it from me, the fracture is healing well.
Right.
But now he's got a different problem here.
Right.
He's got a grade 3 ACJ. Now, firstly we need to ask is why did this happen? And I think I know, because now we've got 2 or 3 of these. A third one is, I think, getting there. So why?
Before you go to that, would many people use a coracoclavicular fixation as well with this plate for this fracture, just to be doubly sure? Is that a common approach, or just the plate is enough? Anybody would like to comment that?
I don't put in an anchor, but I do use a tape and a non-affording patient, a Mercilin tape, and I loop it around the coracoid and bring it on top of the clavicle. So I don't use an anchor as such.
Yeah, this is
the plate.
And over the plate, I would tie it over the plate.
Right. So that's a good point, that we secure the whole construct very well. But here, in spite of all that, the AC joint decided to move away. So we don't know the reason, Dr. Pandey, and this looks very interesting to find out why it should happen that way.
I would use a hook plate from the beginning with such a small, clavicle fracture, because you don't need to fix that fracture. And just by the pressure of the hook plate, the fracture would get in the right position to heal. So, and obviously, this is a very unusual problem that normally doesn't happen. But looking back retrospectively, you can think that that might have looked after this problem also.
Dr. Pandey, is it possible that the soft tissue stripping actually caused the problem when somebody tried to fix it? He actually denuded the capsule completely. Or
Dr. Bedi, you've hit the nail on the head. So people forget that there is a joint next door, and when you make your incision, there are 2 problems here, I think. I mean, unfortunately, this was done by my team when I was not there, but I take the blame because, it's my team, so I have to have broad shoulders. So I think one of the problems is a lot of soft tissue dissection over the ACJ joint to see the ACJ joint. Secondly, not enough soft tissue repair on top. And that's what I keep harping about. You need to have a good soft tissue repair over the clavicle, whatever you do inside. Now, so I think I am reasonably certain that that is what has happened. And despite we putting an additional implant to look after the CC ligament, if the soft tissue on the top and here has been stripped off, this will fail. And this will always fail because when you start mobilizing, the clavicle rotates. And this has obviously failed inside. And now I'm in a difficult situation as to what to do next. And that is why this case is here to be discussed, so that all you big brains can tell me what to do.
Anybody would like to take? You want an answer to this problem from the panel?
Correct.
Okay, so let me ask Shashank if he's there, or Dr. Shekhar Srivastava. Shashank is playing cricket right now, so maybe Dr. Shekhar can come in. Shekhar, any ideas?
I don't think he's here, boss. I think he's also playing cricket.
Okay.
So we have a good match going on. They're not treating it casually. We have a POA match going on. Sorry. Apologies from their side.
How about Raman?
Yeah. So, Dr. Pandey, this is just like a chronic ACJ dislocation now.
Correct.
It's not grade 3. It's still grade 2, type 2, basically. So if you have to treat it, there is no other option but to go back again to the basics. You have to put a semi-T around the coracoid because anchor has failed. So around the coracoid and the coracoclavicular fixation, and then closing the delta trapezial fascia, taking the plate out. There is no other way.
Raman, what do you think? Why is that happened?
Well, that's you explained beautifully. The mechanics, the clavicle rotates. So whatever we do through the clavicle or the coracoid, it's going to disrupt or widen the tunnel, or the implant will give way someday.
Can I just
tunneling devices won't hold.
Can I just
no, but also because initially the X-ray shows that there was no ACJ joint subluxation.
Dr. Pandey, can I ask you something here?
Yeah.
Are you concerned about the integrity of the coracoid here? Is there a coracoid failure? The X-ray on the right side does show the coracoid doesn't look right to me.
No, the coracoid is not broken. We've got another X-ray. I've not put it here. We have a axillary view. The coracoid is okay. But also Raman, there is a slight posterior subluxation of the clavicle.
No, so can I come here to the basic question? Would all agree that type 2, Rockwood type 2 is a complete ACJ, AC ligaments disruption, CC ligaments disruption, complete AC ligament disruption and partial CC, strain of the ligament? Does everybody agree on that?
Yeah, I think otherwise it can't move that much. If
So type 2 is a complete AC ligament disruption. Now, more than these AC ligaments, it's the AC ligaments which produce the horizontal stability. Now, why doesn't the clavicle go posteriorly when the AC ligaments are torn? I think the crux lies with the fascial disruption. When the fascia disrupts, clavicle moves but if the fascia is intact, despite the AC ligaments being torn, clavicle does not move.
Okay, let's have last comment from Dr. Bhasin.
Okay, I would leave it as it is. This is grade 2 dislocation, and grade 2 subluxation is just a cosmetic deformity, and I would just leave it at this stage.
Maybe counsel the patient and leave it as it is.
Yes, I would leave it at this stage.
Okay.
Don't do anything more than that.
Yeah, the problem is he's got this mild clicking and he's got a dull ache and he doesn't like the lump.
And of course, the plate is there, must be pinching as well. The plate is subcutaneous. A lot of these patients want this plate out just for that reason.
Correct. The plate, and that is another thing. He can now feel some of the screws.
Right.
At there.
So what was done, Dr. Pandey? Let's proceed.
No. I haven't done it yet. I am absolutely confused. I agree with Dr. Bhasin. I've been telling him to leave it because I know whatever I do, it's a slippery slope downhill.
So may I propose, Dr. Pandey? You tell him you will remove the plate and follow Dr. Pandey's technique of stabilization.
No, my technique is only working in fresh, new. Within a week.
You will have to add a graft, Dr. Pandey.
Yes,
that's it.
But can we have a look at the pre-op image?
Pre-op image. Sorry.
But if you go in to remove the plate, you must stabilize the joint as well.
Yeah, because here the coracoclavicular distance is disrupted, and I think the coracoclavicular ligaments were already torn, which is pretty obvious out here.
Yes, they were torn. The type 5. Yep.
So more than the posterior translation or the rotation of the clavicle, I feel the repair of the coracoclavicular ligament has failed. And because the bone has healed, the CC ligament has not healed, and there's no vertical stability as such.
Yeah.
As a result of which it is now translating.
Yeah, usually bone heals, everything heals up. If AC joint is okay, nobody has damaged the AC joint on the table, and this fracture heals, the CC ligament automatically heals.
Can we have a next slide? Can you see the next slide, Dr. Pandey?
So I think maybe with this Dr. Bhasin's question, we will close this case, and I will request Dr. Arya to be ready with his presentation. Dr. Bhasin, all yours, quickly.
No, I would leave it. I think the space had reduced after the first fixation. The CC distance, coracoclavicular distance is reduced. And now it has increased again.
So I think the important lesson I've learned is that CC was already torn, which is always torn in such fractures.
Yes.
And if you bugger up the AC while doing surgery, you can expect something like this happening. And of course, now everything is more complicated. Can we tell you very much?
So there was this observation made in the French study that CC stabilization alone is not sufficient to stabilize the ACJ on a long-term basis. Shortly it can do, but 6 weeks down the line, 3 months down the line, we can get this kind of picture. So that is why CC plus AC is necessary.
Can we have Dr. Arya?
Okay.
Thank you, Dr. Pandey. That was educative. Next time I open up this fracture, I better remember your X-ray.
But Dr. Pandey, do you agree that if you have to go there and do something, you will have to put some biological graft there for sure?
Correct.
Yeah.
But I am not going there. I will fob him off till I retire.
You won't get much time for these cases anyway, Dr. Pandey. After the lockdown opens, you are going to be inundated with a lot of waiting lists.
Yes.
Don't worry.
Yeah. We got 5 million people waiting for surgery in UK.
Yeah.
Okay, Dr. Bhasin wants to make the last comment before Dr. Arya starts.
Would a crossed K-wire from acromioclavicular joint across the fracture with a tension band wire be a good fixation option in hindsight? I'm saying in hindsight. That means that the crossed K-wire is fixing from the lateral end of acromion into the clavicle across the fracture site and then put a tension band.
That's what we used to do earlier.
That's what we used to do earlier.
But it needed a lot of immobilization.
When me and Dr. Maheshwari were co-registrars in Indian Hospital, in emergency we used to run after doing the surgery and always the wire would get loose. But now looking at it in hindsight, the AC joint in an acute state could have healed probably, and with a lesser amount of probably soft tissue dissection. Of course, one must repair the deltoid and the trapezius around it.
But it's always in hindsight, so
It's
maybe.
always in hindsight, yes.
Okay, doctor.
I would be wiser if all the panelists can tell me, make me think about it. But
No,
I'm not saying that I would definitely consider it as the last option.
Okay, thank you, Dr. Bhasin. Dr. Arya, all yours.
My case is very simple. There is nothing like like Pandey's case that he sort of put everyone at the trial there. So this was a young chap and who was a keen cyclist and who fell down and had this injury, and it was an isolated injury, no sort of distal problems, neurovascular deficit, no other injuries there. So he came to me, and then I did the surgery after 3 weeks. Although we all have said that the acute injuries, is only up to 2 weeks, but I just stretched my indications a little bit about it. So he had to happen the surgery in about 3 weeks time, and I put the hook plate there. I told him that you would require a second operation to remove the plate later, and he was quite happy about it. And it basically went sort of uncomplicated, no issues there. And as usual, 1 week after he started mobilizing it, and sort of he got the range of movement quite quickly. Actually, he worked hard in that one. And as you can see from the X-rays, that the hook looks sort of into the space there, and it would give rise to problems later if we leave it like that, which is what commonly happens in these cases. So that 3 months post fixation, he did not have any pain or weakness, but he had discomfort in the end abduction and forward elevation. So I removed the plate about 5 months after the surgery, and he recovered quite quickly after that. And this is the X-ray 12 months after plate removal, and he has no issues doing 100 miles of cycling per week. So I sort of just thought to basically for the not for sort of getting the the input from all these panels, but mainly for the delegates who are attending or who are listening to this webinar, that this is just one example of my technique of using the hook plate for these kind of injuries. But having said that, I would again said that in the most problems in orthopedics, there is no one solution for most of the orthopedic issues there, and one problem can have 3 or 4 or maybe more different solutions, and everyone is right at their own place. I think it would be absolutely wrong to say that only my method is right and your method is wrong, and it depends upon what you feel comfortable with, what you are trained with, what's your patient's expectations, and after talking to the patient, what does the patient wants. So same kind of injury in 3 or 4 different situations may require different treatment. And I would only say that, in the hook plate is a simple technique. It's easy to learn, and it's quite a quick method. It's a very strong and stable fixation.
Yeah, so Dr. Arya, you have one supporter to your idea, and that is me, and I will tell you when I use hook plate. Before I say that, may I ask all the other panels, do they Nilesh, hook plate, yes or no?
Only if there's an associated thin sliver on the lateral and fracture clavicle.
Okay, sometimes in the lateral end of fracture. Okay, how about Dr. Pandey? Hook plate, sometimes, never.
Unfortunately, now, no. I have used hip plates before.
Okay,
And I've
Dr.
used
Sinha, you
everything.
are reluctant. You don't have an indication. So, Dr. Sinha, yes or no?
Yeah, like Anand, high demand young men with that type, I would think about seriously then, because I had a lot of lateral plate failures, which may be related to my soft tissue dissection now, but I've used it in high demand men because it works well.
Dr. Kapil?
Under duress, if everything else has failed, but try not to use it. I've got my own term for it. I'm not going to use it here because there are a few proponents for anything.
Okay. So now I use all kind of fixation methods, and I choose to use a hook plate, and I've done it 4 times till now in a very hefty, bulky wrestler, grade 5, or I can say grade 7 dislocation of the AC joint, more or less. And I knew whatever I may fix it with, it is going to fall apart. In a similar case with a lateral end of fracture, something like that Dr. Pandey showed, I know whatever I may fix it, it is going to fall apart. So my indication of using a hook plate, which is a very sturdy device, I agree with Dr. Arya, and for beginners who may not have too much experience, it's a very straightforward operation, except that it has to be removed again. And I think it's in the hands of a little bit of a beginner who are very used to using plates and screws, it's not a bad idea in my opinion. I, of course, use them in a very hefty guy where I know everything else that I use is going to fall apart. I think we'll end this case here. Thank you very much, Dr. Arya. And now next is Dr. Kapil. Yes, Kapil?
Yep. Just give me a second. Coming up. Okay. Right. Can you see that?
Yeah.
So we'll just carry on with the hook plate theme. So this is a 50-year-old man who came to me with complaints of pain and clicking on overhead activities. He'd had a previous injury to this shoulder, but more than 10 years ago, where the said implant was used. And for whatever reason, because I know the surgeon who did it, and he wouldn't have sort of not advised him to take him out, but whatever reason, the plate was never taken out. So it had been in for about 10 years. So he's got a well-healed scar. When you examine him, he doesn't have much significant AC joint tenderness, but he struggles beyond 90 degrees of elevation and abduction, and has got weakness of his rotator cuff. I got a plain film, which is here. So the question now is, what do you do now? First is about further imaging. You probably can't do an MRI scan, so you could do an ultrasound. Do you want to know where the pain is coming from? So you do a subacromial injection, which I did. Improved his pain a little bit, came back soon within a matter of 2 weeks. So where do we go from here? And maybe Dr. Maheshwari, you can ask the panelists, what would they do? Would you remove the plate? Would you remove just the hook? Would you do something else? What are the options?
What is the problem of this patient? Pain?
He's got pain and clicking, and he has got weakness when you test his rotator cuff clinically.
And she's how old?
He is 50 years old man.
Right. So, and of course, MRI cannot be done. So you have to have some method to know whether the cuff is all right. Okay.
Yeah. So we did as I said, I can't remember whether I did an ultrasound or not, but there were concerns. So the option is, the question that I have is that, okay, let's say the ultrasound, whatever the ultrasound shows you, will you do something for him? Do you want to remove that broken hook, or do you want to remove the whole plate? Whatever you do.
Kapil, one question. Once you put the local subacromial, did the power improve significantly? There was post this power improvement.
No, there was no significant improvement in his power, but there was improvement in his pain.
Okay.
So anyway, I decided that I was going to, if I take you back to this X-ray, there's a lot of bone that is overgrown over the top of the screws here. This plate has been in for more than 10 years. So I said to the patient, I said, I don't think we need to go and remove all this metalwork here. We can remove the hook. We'll have a look at your cuff. I'll do an arthroscopy of your shoulder. I'll assess the cuff and I'll try and remove the hook out and deal with your cuff as and if required. So
before you go further, Kapil, now a lot of people have this idea that the hook can cause rotator cuff tear. I think that's a wrong idea.
It's coming.
Okay.
Just wait. So I scoped him. Before I did anything, I did an arthroscopy. Unfortunately, I could not locate the arthroscopy videos, but you'll have to take my word for it. I have never seen a pristine cuff. There was no signs of impingement. The cuff was absolutely smooth. There was no impingement. And I think that is the fact is, and Dr. Arya and others who do this routinely would agree, that you try and put the hook right far back. It is at the angle of the acromion. And the rotator cuff does not, or very rarely comes in contact with that part of the acromion. So if you've done a hook plate properly, your cuff is so far back, it's unlikely to cause significant cuff. Again, I used this phrase before as well, one swallow doesn't make summer, but I found this man's cuff to be absolutely pristine. There was no signs of impingement. So I took the hook out. I just debrided the undersurface of the acromion, did nothing else. And I rehabbed him as I would do for any patient who has had, let's say, a subacromial decompression.
So did you remove the hook arthroscopically?
No, I extended the lateral portal. I thought I'll be very clever, do it, but it was not. So I just extended my lateral portal a bit and I managed to fish it out through there.
So why did you not remove rest of the plate once you're there?
Because there was so much of bone overgrown it. I thought, and we can argue the merits or not, but I thought that was not what was causing his problem. There was so much bone grown in it. I would have had to make a bigger incision and take all that out. So I thought I could just leave it.
Okay. Well, my patients would like everything out once they're in the operation theater. Anyway, that's
okay. My patient, I was able to tell the patient that taking that screw out, if I take you back to the initial X-ray, you see the amount of bone that you've got here. That takes a lot of chiseling away and whatever. And if the plate is not,
my patient trusts the surgeon.
my patient trusts the surgeon as well.
Okay. Prateek wants to say something.
Okay. So the cause of the pain in this case was an acromioclavicular joint arthritis or an acromioclavicular joint irritation. That's what I guess.
So my initial thing was that it was his cuff and impingement or cuff pathology because of the hook, which never turned out to be the case. So anyway, so there is still a little bit of a sting in the tail. We haven't seen the end of it. So just bear with me for a second, indulge me. So I rehabbed him, and about 12 months later, he came back and said, you know what, my pain is better, but my shoulder still feels very weak. I struggle with overhead activity. It's not painful, but it just, I can't trust the shoulder. And he has been doing his rehab religiously. So now, what is the cause of this? And I was quite taken aback, but again, going back to basic principles, I examined him again. And yes, he was not tender over his AC joint. So that answers your question about AC joint arthritis. But his clavicle, I could hold his clavicle and move it from front to back. It was still unstable in an AP direction. The piano key sign was negative. It was stable from superior to inferior, but it was unstable if you held it from front to back and you could move it. So my working diagnosis at this time was that this man's AC joint was still unstable. Now you can argue he's had a hook plate for 10 years. Why should it be unstable? But it was. So I went ahead, I removed the remainder of the plate and I did an AC joint with dog bone and I put an internal brace across his AC joint. Of course, I take the outer 5 millimeters of the clavicle when I do this procedure. And 6 months later, he came with no pain, full range of movements and normal strength, and went back to working offshore. Offshore, they need to really have good strength in an arm to be able to go and work offshore, and everything was restored. So my little learning point from there, that if you use a hook plate, please remove it. Does it cause tough problems in everyone? Maybe not, because if it's quite posterior. But in this case, I think the issues were ongoing subtle instability in his AC joint, especially in AP direction, which was causing the whole idea of the shoulder dysfunction. And that's why you must always evaluate instability in both planes, not only superior to inferior, but anterior to posterior.
So in hindsight, can we say that the fact that the plate broke down, there was instability going on?
But you see, the plate would, after that hook junction is the vulnerable part of that plate. And if you've got constant movement, which is stressing that, the plate will break somewhere, whether that was a consequence of AC joint instability or just metal fatigue. That could happen in any case, because it's got a sharp bend in it. I can't tell you the answer to that. But the fact is that he still, the arguments could be, was his AC joint arthritic, and that was the cause of his symptoms. But we know that most of these patients with AC joint arthritis, they come to us with pain. They don't say that their shoulder is weak. The whole shoulder girdle in this man was still unstable. And once I stabilized it, his symptoms resolved, and he's gone back to normal activities. So the learning point was for me was that you still can have subtle instability causing symptoms.
So when you go in again, keep your mind open. Right.
Yeah.
So thank you very much, Kapil. Anybody wants to make a comment?
Yeah, Kapil, you basically, you can, put it in this way, that you treated a chronic ACJ injury by using your dog bone thing. Is that correct?
Yeah, but that is the interesting thing is that we, what we have learned so far is that hook plate seems to be the last resort if you can't fix an AC joint instability with anything. And I would have expected his AC joint instability to have settled if he has had a plate in for 10 years.
No,
that didn't happen.
I'm coming to a different point. So basically you treated a chronic ACJ injury with your dog bone stabilization, because so far we discussed that the acute injury is up to 2 weeks, 2.5 weeks. And after that, if it should be treated as a chronic injury of the ACJ, and if you're treating a chronic injury of the ACJ, you require something like an excision of lateral end of clavicle and basically a ligament reconstruction kind of things, But here you treated the method which you have used to treat an acute injury of the ACJ. So you treated for a chronic injury of the ACJ with that. So do you believe that this method of using the suspensory ligament things can be used in all injuries of the ACJ, irrespective of the duration, whether it's 3 weeks old or 3 years old?
So now currently I use autograft semitendinosus. This case is about 4 or 5 years old when I was not using that. But during this time, in my unit, I use the semi-T graft. One of my colleagues does not use a semi-T graft. He uses only dog bone or an internal brace across AC joint. And we are looking at our results. Then both of us seem to have equal results. So adding biology, does it make a difference? Once we have reviewed our results, I'll be able to answer that question. If I were to do with this case again now, I would definitely add a semitendinosus. At that time, I did not. So whether I can extrapolate this to my future practice, I can't. The only reason to bring this case here was that you can have chronic residual instability in spite of your fixation method of a hook plate. That was all I was trying to highlight here. It was not to...
Every case can have its own sort of problems and complications.
Very nice. Very nice point.
Secure, yeah.
It's not likely to cause cuff tears. That's another important point. Anybody else wants to make a comment? Anybody from the panel? Or we go to the next case. Dr. Manocha, are you ready?
Yes, sir.
I think Joydeep was trying to say something.
I was just saying a great case, Kapil. I think the key thing also is always consider an arthroscopy to assess those cases. Often I've done those cases where you think it's the bone and the screws, and you go in and you find no damage at all. So have an open mind about that with the plates and screws.
Right, good. Thank you very much, everybody, and Dr. Manocha.
Sir, so my case is also a fracture lateral end of clavicle. That's the X-ray, sir. So it's a 57-year-old female. It's a non-dominant limb. She had a fall. Presentation was after 10 days of the injury. Surgery was at 14 days after the injury. This was last year, just before the lockdown. There is a, please note the cracoclavicular distance with a red arrow. And please note, there is a comminution at the fracture site also. There's a large chunk of inferior cortex, which is away from the fracture site.
So first question, I presume all will fix this patient because of comminution, because of that spike of bone under the skin and lateral end. So maybe some may not, but more, broadly speaking, all panelists will fix. Only question is, how are they going to fix it? Can I have some thoughts on that from Ashish first, and then Dr. Basim from below? Ashish, how are you going to fix this fracture? X-ray laga do, Dr. Banucha.
Sir, okay.
We are not debating whether it will be fixed or not. We are presuming it will be fixed, right?
Yes, sir.
Okay, so how to fix, Ashish, anything? Otherwise, Shekhar, then Raju. Shekhar is not here. Raju, are you there? Raman?
I think we are towards the end.
I thought only I am having beer, rest everybody is attending.
I can give you my opinion.
Okay, please do.
If nobody else is willing to do it, I'll put my head above the parapet.
Please do.
I think the issues are it's a very small distal fragment. That inferior comminution fragment is probably where maybe some part of your coracoclavicular ligaments may be attached. I'll just use I'll use a dog bone device here. I'll do an open vertical incision, put a dog bone device, reduce the clavicle, and so through the clavicle into the coracoid, and that's all I'll use here.
How about anybody take her for a hook plate?
Yeah, so I would, this was exactly the case that I was talking about, that this is where I would do a hook plate and a loop underneath the coracoid, because once it is reduced, that fragment is going to come closer. You don't need to do additional fixation, but once you put in a loop across, it just consolidates. The entire mass just consolidates over a period of time.
Good. So Dr. Manocha, let's proceed.
Okay, sir. So this is an unusual type of injury, which is described as a type 5 injury, as one of the panelists mentioned, that this is a kind of the injury in which the fracture happens at the site where the conoid and trapezoid ligaments are attached, and that these ligaments stay attached to that comminuted fragment, and both other clavicular fragment, they now lack any ligamentous attachment. So the different so I think I'll pass on, but I think the pathoanatomy of this fracture is important. We have understood what will be the status of the cracoclavicular ligament. So we need to know what is the status of the acromioclavicular joint, because if there is an arthritic acromioclavicular joint, excision may be a good idea of such a small fragment. We would like to know whether the intra-articular or extra-articular fracture is present, because again, for an intra-articular, we would go for an excision. And then there's another part. This is a C4 linkage. This is the area of C4 linkage. So in this situation, when the ligament is attached to a third fragment and the clavicle on both sides does not have an attachment, so is it a single or a double disruption? Age, activity, and sports, we all understand how that affects it. So are there any special investigation needed? Because we are assuming that there is a ligaments attached to that third fragment.
Will anybody do any CT scan for this before surgery or MRI? Dr. Nilesh, would you do an MRI or a CT, or this X-ray is enough for you?
No, so X-ray is enough for me.
Anybody would do? Maybe nobody. Okay, go ahead, Dr. Manucha.
Yeah, patient had MRI. We have not ordered this. This is the MRI. I don't think really, as everybody has been pointing out, it adds to our information. But yes, you can see the small blue thing, and you can see that small fragment in it. You are, of course, seeing a lot of edema around the fracture and the hematoma, but there is the AC joint and it looks fine. So classification we have discussed already. So this is what I was talking about.
But this is basically an area of a C4 linkage in which both these ligaments have got detached from the clavicle. Superior and inferior struts are intact. Now, ordinarily, we describe as a double disruption of the superior suspensory ligament, a superior suspensory complex as an unstable. Would you consider this as a single disruption or a double disruption? Because double disruption, because there is a clavicle fracture, there is a ligament. So C4 linkage has a double disruption or a single disruption. So would you plan? Now that question has importance because there are two dimensions of risk management. We'll do fracture stabilization or a coracoclavicular stabilization, one or both, and which one is more critical? That's the question.
Okay, so what you're asking is deciding whether it is double or single will change your treatment.
Yes, sir. And so we in fact have already decided that this requires a fixation. But considering that the double disruption is considered an unstable shoulder or a floating shoulder of, sort of a situation, is this really a floating shoulder? Can this not be treated at all as a conservatively? This is what is the question. And if you are trying to stabilize with the will the coracoclavicular stabilization be enough, or you will need to stabilize the fracture also?
So if I can get your question right, you are going to fix this clavicle anyway.
Yes, sir.
And in addition to clavicle fixation, would you add a coracoclavicular construct of some kind? Is that your question? Sir. Right. Yes. So maybe we can quickly ask, starting from Dr. Arya and then Dr. Pandey.
Yeah, I mean, this case requires fixation. Probably that is undisputed. And as I said, that there are several different ways you can fix it. But probably here is a case that you should try to do maximal fixation. Mm-hmm. So basically, you fix the fracture as well as add some sort of coracoclavicular construct also in that one. So, I mean, by now, people would know what I would say. So I would obviously use a hook plate to fix the fracture. So you don't need to fish for the small fractured fragment. You don't need to fix them. Just fix the plate to the main body of the clavicle and the hook to the acromion there. And then after that, some sort of coracoclavicular construct can be added. So that probably would make it, quite secure. But I know that, people can have different ways of achieving the same goal.
Dr. Arya, do you think just plate alone is enough? Because once the fracture heals, everything will actually get glued together.
I think that fragment. You should. I mean, that would be perfectly acceptable option. I mean, nobody can say that you did not do the right thing if you only do the plate, because the thing is that there is a small bony fragment also attached to the end of the coracoclavicular ligament. So once you bring that small fractured fragment to adjacent to the main body of the clavicle, that should heal, and that should give rise a good healing to the coracoclavicular ligament also. So I suspect that, you can take this decision on the table. And if you feel like that, yes, there is I mean, it mainly depends on your gut feeling at that point. But what I'm saying is that it should be perfectly all right just to give a good fixation with the hook plate. But if additionally you want to do something, you can add, some sort of, a kind of a.
Dr. Pandey, anything different? Dr. Pandey?
Yeah, I think firstly, someone said this can't be treated non-operatively. I disagree. It can be treated non-operatively. It depends on what kind of patient you have. If it's a 57-year-old non-dominant housewife, if you want to give it a trial of non-operative management, you're fine. You got two bones which are nearly there. Clavicle fractures, worse ones have healed. If it doesn't heal, you can always intervene. There are a lot of people with non-union of lateral end of clavicle who are functioning absolutely fine. So I think both options should be given to the patient. This is not a life-saving surgery. So even if it goes into non-union, this can, the patient may be okay. Having said that, if this was my arm, I would have preferred some sort of intervention. And I think I would still treat this without any metalwork with absorbable sutures, because if I get the bones together and do a nice soft tissue repair on top, I'm reasonably certain that the bone will heal without me having to put metalwork. Now, having said that, there is enough bone laterally. You can use the modern lateral clavicular plate because they have very small holes. You can put almost 2.3 millimeter screws. So you can put 2 or 3 screws in the lateral bit because it's doesn't look very committed, although it's very difficult to say. But again, it's very important that you don't disrupt the ACJ ligaments, otherwise you'll end up with a dislocation like I did.
Right. So Dr. Manocha, as you know, most people will fix, though Dr. Pandey is even considering non-fixation. And his technique of non-metal technique has become the most favorite one this afternoon. So you can proceed now. What do you did?
Yes, Dr. Maheshwari, can I ask one question?
Yes, please.
It looks like that the CC ligament is not, as with the discussion, it may not be torn. It's just that it revolves with the fragment.
Yeah, that's right.
So
that's what he has shown in the picture.
Yeah, so CC ligament, yeah. So not necessarily that we need to do something for CC as long as we can get it to heal to the bone.
Yeah, maybe some kind of approximation of that fragment to the main bone would be
is required. Yeah.
Required.
But
Right.
Dr. Maheshwari,
Yeah.
if you put a lateral clavicular plate, the CC ligament will still be away. If you put a hook plate, then CC ligament can approximate.
That really wouldn't make any difference because
if you put only a plate on the top, the CC ligament will still be away.
No,
a hook plate, CC ligament will come closer.
I don't think that will matter because the fragment is attached to the ligament and the ligament is falling apart. Whatever you may do on top will not make any difference to that small piece of bone which carries the ligaments.
Yeah, but if you have a hook plate, then the clavicle comes closer to the acromion, and then secondarily the CC ligament will come to a better place. But only if you put a plate on the top, like what Dr. Pandey showed, only the top plate, then the CC ligament will still be far away. Dr. Raman has to say.
Dr. Bhasin, I have used, as Dr. Pandey mentioned, I have used lateral and clavicular plates in this situation successfully in the past in a couple of patients. In one patient, I could even engage that avulsed fragment with a screw. So because the AC ligaments are intact, so theoretically and practically speaking, the lateral and clavicular plate should also work, not only the hook plate.
Everything well. It's a question of the hematoma getting ossified and everything.
Yes.
It's just that. Okay, Dr. Manocha, let's proceed.
So this is what was done, sir. Like like Dr. Kapil said, that it was with a dog button fixation of the medial clavicle and trying to reduce a little bit of the lateral fragment also onto it so as to approximate the avulsed fragment right to the closer to the clavicle. This was done. The coracoid, that placing the button was done arthroscopic assisted. So this is some arthroscopic pictures. So that's the button.
So did you try to take a suture through that small fragment to bring your fragment closer to the clavicle? Or did it just come by itself?
Yeah, it came by itself. I didn't even try to locate it. I focused on a reduction of the fragment from the above, bringing the middle fragment down closer to the coracoid as much as is possible, and trying to bring the lateral fragment in line with the 2-3 K wires. This K wire, I prefer these K wires because for the same reason it was mentioned, because they can be done just by feeling. You can push them into the clavicle, and you don't need to dissect really the AC joint, and will not cause much damage to the AC joint. They can, of course, be removed even after 3-4 weeks only, and that is just a small nicks and percutaneous surgery.
Yeah, I think Dr. Pandey's case is something that will carry in my mind for a long time, operating on these cases, because we orthopedic surgeons look at the bone all the time, and sometimes trying to locate the bone, we cut away everything and don't bother, and that's what happens, what Dr. Pandey showed. Anybody wants to make a comment?
For the same reason, the Arthrex has got this lateral and clavicular plate with inbuilt capacity for a dog button.
Okay.
So that you could augment your CC fixation in a lateral and plate with a dog button over the lateral and clavicular plate.
Yeah, they have a specially designed bowl in which that dog button sits very nicely. Yeah, I agree.
Yes.
I think the Acumed also had an AcuCinch plate similar, but I think these things are quite expensive.
Yeah, very expensive, very expensive.
And they sort of sometimes they're not technically so easy to do. You really need to be doing them day in and day out.
Yeah, it's very interesting. On one end we have Dr. Pandey, and on the other end we have all this stuff, and giving the same result.
I think the evidence in 5 years will prove Dr. Pandey absolutely right.
Right.
I agree with you there. And so I think that end this session case presentation, and I think I should now invite my colleague Dr. Basim to sum up, give some carry-on message in next 2 minutes.
Okay. This is just one slide, sir. This is 7 months follow-up. That fragment has come and closed. So we could not remove the wire early because lockdown happened, and this wire was removed 7 months later. But fortunately, I had buried it under the skin, so it didn't cause much of the problem.
So, Dr. Manocha, do you notice the massive ossification in the CC space?
Yeah, it was only because this wire had to be retained much longer.
No. It is a complication of the tunneling devices and the CC fixation devices.
In this case, fracture itself would have caused so much, ossification.
Yeah, could be.
There's so much fracture there, hematoma there, all that.
Yeah, there, this one.
Yeah. So in this case, I think fracture itself would have caused so much callus formation and all those things.
A lot of combination, there would be a lot of hematoma.
Yeah, right. Dr. Basim?
Okay, I'll take 4-5 minutes to say what I think I have been.
Can you unshare, Dr. Manocha, unshare? Let's have the panel here.
Yes, sir. Yes. Yes, sir.
Okay. सर अपना ऑफ करो, म्यूट करो. नहीं किया. Okay. Yeah. Okay. So, listening to all the talks, all the aspects which have been well covered, I must congratulate Prateek for having such a wide variety of coverage on this topic, that we have seen everything from all sides, rigid, mobile, flexible, graft, and all the options we have seen today. Looking at all these, I am reminded of the old Indian text called Kam Sutra, which says that there are many ways of doing the same thing. And nothing probably supports the old Indian treatise than what we saw today, that there are many ways of doing the same thing. But in nutshell, I would still like to give 1 or 2 clarifications which I think are important. I think there are 2 or 3 things. One, that we must look at acromioclavicular joint not only as a vertical stabilization, which all the coracoclavicular fixations are doing, but also as a horizontal stabilization, which is across the acromioclavicular joint. So both the aspects of the acromioclavicular joint, the vertical as well as the horizontal aspects, have to be addressed. We must understand that we are suspending the entire weight of the upper limb on that fixation. It is not that we are supporting the clavicle. It is the entire upper limb weight we are trying to support with that Marcelin tape, with whatever device which we are thinking. We must understand that this is the limitation why most of the procedures have an inbuilt recurrence of the symptoms, because probably A, we address vertical by addressing the coracoclavicular ligament by whatever methods, and B, that the weight is tremendous on those devices. Dr. Nilesh spoke about suture and button fixation. I hope if you do it in an acute stage, the vertical component of coracoclavicular ligament has to undergo a biological healing for this technique to work. if that biological healing of that coracoclavicular ligament can be proved by any of the imaging method, then only do we expect this method to be viable and long lasting. As far as the method of tape and dog button was concerned, the hook plate does offer simplicity, but it is a procedure which is not which may not address all the problems. I feel that a combined approach of vertical as well as a horizontal stability will be the way forward. We are vertical stabilizers, most of us, and maybe somewhat horizontal stabilizers by repairing the soft tissue. But probably the way forward will be a combined procedure. The Weaver done procedure has a limitation of the strength of the graft, which is only 1/5. And also, again, it's a vertical stabilization procedure. What Dr. Pandey spoke was very innovative. It is flexible. It is addressing the vertical as well as to some extent the horizontal component also. What he's doing across the figure of 8 and the box fixation. So although both are flexible, but it addresses both the issues. I feel that in a chronic situation, an autologous graft is essential for any biological success. This is what I would say that I have learned through the day.
I think one point I'd like to highlight is the soft tissue healing is very important for success of this. Till maybe 10 days, 2 weeks, you can hope for the best that natural healing will take care. After that, whatever fixation you may use, if there's no good attempt at soft tissue reconstruction, and if soft tissue reconstruction doesn't happen, any procedure will fail in long term. So I think, these are the basic points that have come up in the talks today. And I compliment everybody, all the panelists, all the presenters for really doing a good job. It was a very nice afternoon spent. Thank you, Prateek, for organizing this. And of course, we are enjoying the hospitality as well. Thank you very much. Is that okay, Dr. Prateek? Anything you want to say?
Yeah. No, thank you so much, sir. Anything, any panelists want to?
Can't hear you. Unmute.
Sorry, I am unmuted.
Yeah, I can hear you, Prateek.
Can you hear me?
Yeah, we can hear you.
Yeah, so
is the meeting time over?
I am.
Can't hear Prateek.
Okay, can you hear us?
Yeah, we can hear you.
Yeah. So, no, I wish to thank you, Dr. Maheshwari, and all the faculty for conducting it with the whole session very nicely. Yes, it was a very informative as well as fruitful discussion on a topic, because when we started, everybody said ACJ, it's such a small topic. What would we have to discuss? And there was that whether we will have 3 hours discussion on it or 4 hours would be controversial. But then obviously we proved that we had a little more time, we could have accommodated a couple of more cases and have had even better discussion. So I wish to thank all the faculty, the foreign and as well Indian faculty for taking out time. I know it's lovely afternoon there for all the people in UK. They have spent that with us, brightening our information and skills. The Indian faculty, the delegates, and obviously all the people who have supported this meeting, especially organizing team, my colleague Dr. Ashish Acharya, Dr. Naveen, Shashank Mishra, Raman Kant. Raman has given a lot of inputs in the scientific content. As Dr. Basin was saying, we've got mixture of everything. So we tried to touch everything together. Dr. Ashok Sham from OrthoTV, obviously they've organized it quite well for us. So I wish to thank all, and my secretary, Shalini, whose mails you have been getting, and everybody else who has contributed, who I may have missed, including the other faculty members as well as the delegate. So I wish to thank all of you for this lovely evening, and hope to have you again on this same kind of platform with some other interesting discussion.
Prateek, would it be possible to get some feedback from the delegates that, about different talks. I don't know whether you have arranged it or not, but
Yeah.
if you can just get some feedback from delegates, so
Yes.
then that would be very useful.
Yeah, Dr. Arya, we do it every time. What we do is we have got all the emails, because this time also we have all registered on the web. So we got the emails. So we had written to them that we would need a feedback. So tomorrow a mail will go to them of thanks for joining, obviously, and also a feedback on individual talks and how we can take this further. As I said, it is 17 years that we've been doing. So we take a little feedback and try and see if we can do something different or better next time, so that it will be more useful for the group of people that we address, the young budding orthopedic surgeons here.
Thanks, Prateek.
Yeah.
Thank you.
Thank you, Prateek. Excellent. Thank you, everyone.
Thank you so much.
Bye-bye.
Thank you.
Bye.
Thanks, friends. So I'll leave the meeting.
Thank you.
Thank you so much.
Thanks. Brilliant.
Thanks.
Thanks a lot, everyone.